Good evening, sir. Rajgopal, sir.
Good evening, Dr. Kanakar. Good evening.
Good evening, sir. Good evening, sir.
Good evening, sir.
Good evening, sir. So good evening.
Good evening.
Rohan, are you with us? Rofal,
Yes, sir. Yes, sir. I'm ready.
can you please switch on your video? Professor Anil Sundaram, sir. Good evening.
Good evening, sir.
Welcome, sir. Welcome. Welcome.
Thank you, sir.
Rofal,
Yes, sir.
I think, Rofal, can you try sharing your PowerPoint?
Yes, sir. I will try.
Yes. So, good evening, friends. It's 8 o'clock. I warmly welcome the senior faculty, Professor Shanai, sir, Professor Rajiv Sakai, sir, and we have Professor Anil Sundaram joining us for the first time. Kindly introduced by Professor Sri Kumar Ramchandran from GMC Trivandrum. And sir was telling that he's been watching the classes during the Corona time also. So thank you, sir, for joining us. We have two postgraduates joining today. One is Rohal from GMC Trivandrum, again kindly contributed by Professor Sri Kumar, sir. And we have Dr. Ishan. Ishan is going to present second. Ishan will be presenting a case of a mass abdomen from Government Medical College, Chandigarh. Thanks to his chief for kindly permitting him. Now we'll have Rofal to start with the first case. Rofal, please introduce yourself. We are unable to see you, Rofal. You have to switch on your video. We are able to see your slides.
Yes, sir. I have switched on, I think.
Okay, good. So good luck to you. Professor Anil Sundaram, Professor Shanai, sir, and Dr. Sakai, sir, please take over. We expect Ibrahim, sir, to join shortly. And let us go ahead with the presentation. Karnakaran, sir, may not be joining because I think they have a PG Surgicon at Madurai Medical College. Others are expected to join. Dr. Rofal, you please introduce yourself, your unit chief, head of the department, and start your presentation. Good luck.
Good evening, respected faculties. I am junior resident in Department of General Surgery in Government Medical College, Trivandrum. My unit chief is R.C. Srikumar, sir, and my HOD is Abdul Latif, sir.
Rajesh, sir, shall we start the presentation?
Yes, sir, please.
Yes.
Please, sir, please start, Rofal.
Okay. Yes, roughly can start.
Good evening, all. My patient is a 46-year-old male from Kollam. He is working as a taxi driver. He has presented with a swelling in the left groin for past 6 months. Coming to the history of present illness, patient was apparently normal 6 months back when he had noticed a swelling in the left groin, which was insidious in onset and was gradually increasing in size. The swelling was not associated with pain, and there was increase in the size on straining and coughing, and it is reduced in size on lying down, and it was not associated with any period of irreducibility and not associated with any abdominal distension, vomiting, constipation, and there is no history of chronic cough or breathlessness, and there is no history of chronic constipation or straining for stools, and there is no history of dysuria, frequency, urgency, or nocturia or dribbling of urine, and there is no history of any acute retention of urine in the past. Coming to the past history, there is no history of any diabetes mellitus, hypertension, chronic obstructive pulmonary disease, bronchial asthma in the past. There is no history of any surgeries or hospitalization in the past, and there is no history of any long-term drug intake. Coming to the personal history, he consumes non-vegetarian diet His sleep and appetite is normal. His bowel and bladder habits are normal. And there is no history of any addictions. And there is no drug allergies. Coming to the family history, he is married 20 years back and he has 2 children. And there is no history of any similar illness in the family. I will summarize my history. My patient is a 46-year-old gentleman. He is a non-smoker. He presented with a reducible swelling in the left groin since last 6 months with no associated pain, and he has no any comorbidities or surgical history.
Dr. Rafal, please get back to the first slide. The faculty will be questioning you from slide after slide. Faculty, please take over. Thank you.
Okay, Dr. Rafal.
Yes,
what do you think is your diagnosis by your history?
from the history, it is an inguinal hernia, which is uncomplicated, sir.
Why do you think it's inguinal hernia? Can't it be a femoral hernia which is reducible?
Since
Why
it is
do you
the
think it's inguinal hernia?
sir, as it is the most common, I will consider inguinal
It
hernia
could be
as
the
the
most
first.
common. It could be the most common.
Sir.
So an answer would be a groin hernia.
Yes, sir.
Right? That covers both. Right? So if you ask, some people always answer inguinal hernia. Well, it could be this thing. It could be, right? Okay.
Okay, sir.
So why do you think it's a hernia, not anything else, just by history?
It is in the anatomical site of hernia, first thing, and there is history of it is a reducible swelling, and sir.
So it's got a swelling where in the groin, right?
Yes, sir.
And it's a reducible swelling. So can you tell me other reducible swellings in the groin which are not a hernia?
A lymph node swelling, sir. Then
I asked other reducible swellings which are not hernias.
reducible swelling, sir.
Yeah. Dr. Rafal, just widen your perspective. Just stay in hernias. Are there any other swellings which can reduce, which are not hernias? A varicocele?
Yes, sir.
Right?
Yes.
Saphenopharynx?
Saphenopharynx, yes. Saphenopharynx.
These are swellings which can appear in the groin region, right?
Yes.
Right. Okay. So no history of abdominal distension, vomiting, constipation, and pain. Why did you ask for that?
To rule out the features of any intestinal obstruction, sir.
Okay. So you think that its content was intestines?
Yeah, from history, sir, I can't differentiate the content, but it can be
Right. So
intestinal.
it could be good. Okay. So okay, next slide, please. Chronic cough, breathlessness, straining for stools. What is his age? 42.
46-year-old, sir.
46. Okay.
Sir,
So,
can I add one more?
Yes, please, sir.
Rafal, you stressed on the point regarding pain. So what do you think is a cause of pain in such a reducible swelling in that area?
Sir, it can be an aching type of pain in patients with initial presentation. And if there is any features of obstruction, there can be colicky pain also. And if there is triangulation, it can be a persistent pain.
So that is the
Can there
importance
be
of
pain? Sorry, can there be pain without any of these features of strangulation and obstruction? Can there be
There can be, sir, a aching type of pain due to the pulling of momentum, sir.
Right. So that could be also a cause. Very good.
Okay. Can the pain, that sort of pain, can it be referred to somewhere else also? These sort of pains?
It can be periumbilical regions.
Okay. Any other particular thing? Because you have got, if you are suspecting bowel, along with the bowel, something else will also come. No, what is that? What of the bowel also comes along the hernial sac?
Mesentery of the bowel.
Mesentery also. Mesentery. So in those cases also, the patient can have pain getting referred not only to the periumbilical area, any other area also can the patient have pain? Upper abdomen. Upper abdomen also the patient can have pain when the medicine, because in relation to the mesentery that is getting stretched.
Okay.
Okay, sir.
Raphael,
so-
Raphael, one or two
Sir.
questions from my side. What is groin?
The groin is the area where the thigh contacts with the abdomen, sir, lower area.
So you just have to say lower abdomen with the upper thigh.
Yes, sir.
So when you say groin hernias means what are they included?
It can be femoral hernias or inguinal hernias.
So both direct, indirect, femoral, all that is whatever portion adjoining. That's what constitutes the groin hernia, right?
Yes, sir.
You have seen so many, you have written there all those things, constipation and all that thing. I just want to ask you one question. He's 46. If he has any urinary complaints of all these things, other than the prostate, what are the things you have in mind? Like you have written dribbling and all that things.
Stricture can be there, sir. Urethral strictures can.
What are the common causes of stricture in that, suppose, let us say, 35, 45, this age group?
It can be calculus or
Calculus will not produce stricture. Like, see, we would like to know what are the causes of stricture, if at all. Earlier, what was the disease used to be common? Now it is not that common. Gonococcal urethritis.
tuberculosis.
Tuberculosis, nobody can rule out 100%. Genitourinary tuberculosis. There are various other manifestations. It won't produce like this. So we'll ask you, there are so many other manifestations, genitourinary tuberculosis. Trauma. You should never forget trauma.
Okay, sir. Okay, sir. Yes, sir.
So the typical that manhole type of, you heard of that trauma. So trauma, urethric trauma. Second is instrumentation.
Yes, okay.
What is it? Why do they instrument, suppose this person, 46-year-old person?
Sir, I can't get this.
Why do any urologist will do some intervention? Intervention means urethroscopy or something.
Yes, sir. Yes.
What is the reason? This
Sir,
is
I can't get the question, sir.
what I'm trying to tell is instrumentation today is one of the causes of a stricture.
Okay, sir. Okay, sir. Yeah.
Whether it is impacted stone there or whether they want to do some URS, whether they want to do some, get some urine sample from one of the ureters, whatever be the reason. Instrumentation, then iatrogenic, then of course the trauma, then you have an infection like you mentioned about gonococcal urethritis, etc. So these are some of the causes. Okay.
Okay,
If
sir.
it is a gonococcal urethritis, next question is which part of the urethra gets affected? So next question will be what is the length of urethra in men and what are the parts of urethra? Please get ready for all these questions whenever you have it, patient like this. Okay, because you have written that dribbling and so many things. I would have appreciated if you would mention smoking here.
Yes,
You
sir.
understand? Especially collagen deficiency. So you have to correlate that rather than you mentioned about dribbling of the urine and so many other things, right?
Yes.
So these are some few questions, sir, from my side.
Yeah, Dr. Rofel,
Yes, sir.
like Professor Rajgopal said, for obstruction to urine in a young male, you should start from the tip of the penis. So phimosis, meatal stenosis, then strictures, then bladder neck obstruction. Should go that way.
Okay, sir.
Okay.
Okay, sir.
What about weight, lifting heavy weight? Is it a predisposing factor for
Sir,
hernia?
It was previously considered, sir, but it is not considered as a cause as now, sir.
Why? What was the evidence against it? How did they decide that it's not a cause of hernia anymore?
Weightlifters usually doesn't have
Right.
hernia, sir.
Right. Okay. So long-term drug intake. Why did you ask for that? Which drugs are you interested in?
Sir, if patient is having any prostatic hyperplasia or something, if patient is on any routine medications.
Okay, chronic UTI or any this kind of
Yes.
thing, right? For COPD. Okay. Next slide, please. Okay, that's fine. So, should we go to the examination, sir? Okay,
Yes.
Dr. Rafael, you can go to the examination.
Rafael, then 46-year-old with the no precipitating factors in your case. So what may be the reason for occurring with the hernia?
Okay, yeah, that's a very good question.
Because you
Why do you
said,
think he's got a hernia?
yeah, so that's important. He's
Sir.
not weightlifting something, all that you mentioned.
Yes, sir.
Yes.
Sir, from history, I can't differentiate it from.
No, answer to the question.
No.
Okay, sir.
Forget about
Answer the question.
differentiation. I asked you a simple question.
Sir, congenital weakness of the wall can be the cause.
No. You
No.
think under
Or
You think yes?
you have heard of prune belly syndrome? What is it?
Reopening of processes vaginality.
So
Vaginality.
that is what you should even answer. No doubt is 46 little that way. More or less persistent processes vaginalis fact. Relatively common in young, no doubt. But you don't know. It can manifest at 35, 40, 45 also.
Yes.
Here comes the history of a strenuous work. I'm not trying to say weightlifting is not the answer. It is not like that.
Okay.
At some stage of activity, some fibers might have caused a weakness. Adding on to this processus vaginalis, whatever the persistent sac, might have manifested this age group. That is what is important. Okay.
Yes.
Your answer should
Okay,
be-
Sir,
Dr.
may I
Rafael.
ask, sir?
Yes.
Good evening, sir. Doctor.
Good evening.
Okay. Yes, sir,
You
sir.
are saying the provided if it is a persistent processus vaginalis, what kind of hernia it will be?
It could be, sir, indirect inguinal hernia. Sir.
Okay. So that will come to just remember this, whether it is a direct or indirect.
Yes.
Another question. What do you mean by similar inlays in family?
I want to just rule out, sir, any congenital causes of collagen deficiencies like Marfan syndrome or something. If similar history in the family will be.
Now you have written no similar illness in
No,
family.
yeah, yes, sir. He has written that similar illness in family. See, Raufel, what first I ask is, see, you have mentioned regarding some congenital problems as sir just mentioned, prune belly and all, where you have the
Yes.
persistent. Apart from that, are there any genes actually associated with this thing, the persistence of process vaginalis, or that if that gene is there, or if that gene is mutated, it can cause decrease in the retraction of the process vagina.
Yes, sir. Hepatocyte growth factor gene and calcitonin genes.
Calcitonin?
CG.
Calcitonin gene-related peptide.
Gene-related peptides, sir. Yes,
Calcitonin gene-related peptide and the hepatocyte growth factor. See, that is the main thing. See, when there is no predisposing factors, we must always think in terms of these genetic problems also, because they itself can cause weakness as well as decrease in whatever process vaginalis that remains, or decrease in the retraction of the process vaginalis.
Yes.
It can predispose to such a cause.
Okay. So you have written that no past history of bronchial asthma. What do you mean by that? Goes one slide back. Just I wanted to clarify it.
Sir, if patient bronchial asthma patient can have chronic cough, sir, it can
No.
predispose.
What do you mean by bronchial asthma in the past? So does it disappear, asthma, after some time?
No, sir.
No.
No, sir.
So patient is not a known case of asthma. That should
Okay,
be,
sir.
or chronic pulmonary. That's okay.
Okay, sir.
Right? So suppose this patient had some predisposing factor like a stricture urethra or anything. Which type of hernia will it likely to be?
Sir, it can be direct hernias.
Not necessarily. That's the trick question, I would say. That's what say persistent process vaginalis may be there, and this predisposing factor will increase the chance of developing.
Okay, sir.
Right? Okay, please do examination.
You bronchial asthma.
Just
What is
a
the
minute.
the hernia? Asthma and hernia or lung disease and hernia. What is the relationship?
Sir, no, sir. If there is asthma, he can have a chronic cough for.
No, other than that, other than the chronic cough, is there is any other? What is metastatic emphysema of reed?
Sir, increased in elastase enzymes can cause.
And the misbalance between the antitrypsin and elastin. So that is the same mechanism can act on the hernia where the collagen tissue also go about. It is not necessarily only the cough. So
Okay.
Sir has very well explained. Please do not think that all these are only cause for a direct hernia. So
Yes,
all
sir.
these factors can be the reason for developing a indirect hernia also.
Okay, sir.
Sir, one more thing. Say you have mentioned that it is a reducible one. No, it is a
Yes, sir.
reducible. See, how do you define a irreducible hernia? How do you define? What is the definition for irreducibility?
Apart from spontaneous reduction, patient himself can reduce the swelling.
No. See, you say irreducibility when the contents cannot be returned back to abdomen and they are at high risk of complication.
Okay.
At high risk of complication, that is the term. Okay, it cannot be returned back to abdomen with high risk of complication is what the correct term is. I mean, definition we will give for, because you have been saying that it is reducible and reducible. Okay, so in that context, can be asked whether it is reducible or how do you define an irreducibility?
Okay, sir.
Okay.
Can we go to the examination then?
Okay, sir. Coming to the general examination, he was examined in a well-lit room with adequate exposure and consent. He was examined in both standing and supine posture. He was conscious and oriented in time, place, and person. He was well built and nourished with BMI of 23.8. His pulse rate was 76 per minute. It was regular in rhythm, normal in character and volume. His respiratory rate is 18 per minute. His blood pressure is 120/80 millimeters of mercury in right arm. And there is no history of any, there is no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy or pedal edema. Coming to the local examination, on inspection, there is an oval-shaped swelling of 6 × 5 centimeter in left inguinal region, extending up to the root of scrotum, and the skin over the swelling is normal, and his position of penis is central.
Yeah, go on.
Okay. Coming to the palpation, there is no local rise of temperature or tenderness over the swelling. On palpation, there is a left-sided inguinal swelling of oval shape with 6 × 5 centimeter with regular margins, smooth surface, and duffy in consistency. And it is not possible to get above the swelling, and swelling is reducible, and there is expansile impulse on cuff. Deep ring occlusion test is negative, and leg raising test shows abdominal muscle tones are normal, and there is no malgainis bulge. External genitalia is normal, and on percussion there is dull knot over the swelling, and on auscultation there is no bowel sounds heard over the swelling. And examination of the opposite side, that is right inguinal region, shows no swellings with cuff impulse or inspection and palpation. Coming to the systemic examination, examination of abdomen. Abdomen is normal in shape. Corresponding quadrant moves equally with respiration. Umbilicus is central and inverted. There is no scars, visible pulsations or peristalsis. And on palpation, abdomen is soft and non-tender. There is no palpable mass or organomegaly. There is no free fluid on percussion. Bowel sounds are heard normally. Coming to perectal examination, anal tone is normal and there is no mass or prostatomegaly. Respiratory system, air entry is bilaterally equal and normal. Cardiovascular system, heart sounds are heard normal, and there is no focal neurological deficits. And my diagnosis is left-sided direct inguinal hernia, uncomplicated with omentum as contents.
Dr. Raffel.
Yes, sir.
Could you go back to your first slide of examination?
Yes,
Oh, that's right. Next. What do you mean? Why did you say penis is central? What do you do? How does it help you? If the penis is central or ectopic or something?
a large
Move to
swelling
one
can
side.
push.
So how does that help you? It doesn't.
Yes, sir.
I mean, that fact is useless. It doesn't convey anything, right?
Yes,
So
sir.
you're a surgeon. Don't come up with these kind of things.
Sir, one.
Okay. Does the swelling now when the patient lies down? Does the swelling disappear?
Yes, sir.
Okay.
Swelling
Then how do you
decreases in size,
percuss?
sir.
Okay,
Decreases in
doesn't
size. It doesn't completely disappears.
Okay. So do you think percussion is a just next slide, please? Next slide, please. Do you think you can percuss this hernia? Is
On
percussion a test for hernia?
standing position, I tried.
No, what information do you get by percussion?
Sir, just to look
Suppose
for
it was resonant. Suppose it
Yeah.
was resonant. What would you think of?
content maybe
There's air
bubble.
inside. It doesn't help. There's nothing called percussion of a hernia.
Yes,
Like
sir.
there's nothing called percussion of a hydrocele. Right. Also, next slide. You've examined. You said external genitalia are normal.
Yes.
Have you seen the external meatus? Is the prepuce retractile? Have you palpated the urethra, the penile urethra?
Yes, sir. There was
You've
no.
not written anything. You have to write. Look, Dr. Rafael, if you are
Yes,
going
sir.
to rule out stricture, suppose you do a hernia repair and it goes into retention and you try to put in a catheter, it's not going to go. Then what? You're stuck.
Yes, sir.
You've got a mesh up there, right?
Yes, sir.
So, yeah. Sir, please. Sir.
Rafael, inspection, just show that slide once for me.
And you should have had a photograph, Dr.
Yes,
Rafael. A
yeah,
photograph
yeah.
would have been appreciated.
See, what is the diagnosis sign of hernias?
Reducibility and cough impulse, sir.
No, not reducible. There are so many swellings can be, but cough, expansile impulse and cough.
Expansion. Yes.
Now, when you ask the patient to stand, you saw this oval swelling, correct?
Yes.
What did you do? Did you make him to cough now?
Yes, sir.
Why didn't you write there?
Sir.
Nothing written.
Where you have written? See, you have only written position of the penis, which is not.
Sir, it is.
Yes.
No. Inspection.
It's in palpation.
Inspection.
Yes, sir.
So please do not take it for granted. If there is already a swelling, it can be lipoma. Who knows? So that is why you have to mention, as you ask the patient to cough, it expands. You understand? No.
Okay, why if you suppose you didn't get a cough impulse, what would you think of?
In irreducible hernias, if contents are, I may not get the cough impulse, sir.
Yeah, in a irreducible. Okay,
Yes,
that
sir.
could be fine. Any other reason when you don't get a cough impulse?
I don't think so.
That's fine. That's the only one. Okay.
Okay.
So,
Sir, can I ask how many points you have left out in inspection? So many of them.
Yes, that is what I was trying to tell him. You should, maybe a PG exam doesn't mean that you should vomit all that thing. Okay. Surface, border, diffuse or diffuse, shape, all that you have to give any peristalsis or anything seen rather than mentioning that position of the penis.
One more point.
Yes.
Normally, I don't know about others, but what we teach is bilateral area. Normal side should be said first. The right side is normal. It's up to okay. That's what we say. Second point, have you examined patient in lying down and standing, inspected?
Yes, sir. Both, sir.
So what happened to swelling in lying down on inspection?
Sir, swelling decreased in size, sir. It was not
It
completely.
does not disappear, right?
Yes, sir. Yes.
So where is it written?
Yes, sir.
Do you understand?
Yes, sir.
This is the important point on inspection. Impulse, reducibility, if it is there, and change in the size on inspection.
Yes, sir. Sorry.
Sorry, it's okay. It doesn't matter. But the inspection only 3 lines and palpation 15 lines. I don't know. And still you are saying inspectory findings were confirmed? What do you mean by oval swelling? Normally, what will be the swelling in case of direct hernia on inspection and in indirect hernia?
Sir, globular, usually direct hernias are globular and indirect hernias are pyriform in shapes.
So why indirect hernias are pyriform?
Sir, it is extending through the inguinal canal to the scrotum, sir.
No. What is the reason for giving a typical pyriform shape?
Sir, it's extended through the external ring.
Yes, it passes through the external ring. So it suggests it is going along with the cord.
Yes.
So what is bubonocele?
Bubonocele is the hernia which lies inside the inguinal canal itself, sir.
So this was not bubonocele.
No, sir.
It was not bubonocele. Right. So when you have inspected, you saw that it is not reducing completely on lying down. What will you think? Does it give you any hint on inspection?
Sir, it can be due to chronic hernias due to adhesions.
So if the hernia does not disappear completely on lying down, which type of hernia is it likely to be? Direct or indirect?
Indirect hernias.
It is indirect hernia. So on inspection, that is an important finding, right? You have mentioned only skin over the swelling is normal. So on inspection, as you have said in abdomen, here you have to see what is the position. Penis, you have said. What about testis?
Testis, sir, I have mentioned in palpations.
Not inspected.
Yes.
So up to which level the swelling extends on inspection after impulse on cuffing?
It is up to the base.
The scrotum, you have said. What does it mean?
Yes, sir, base, root of the scrotum.
Root of the, what does it mean? What does it mean?
Sir, just below the external ring, sir.
That all you can inspect, external ring.
No, sir, I can't.
So what do you say and in which context? Testis is visible or not?
It is visible, sir, separately.
So not mention anything about inspection. Please carry on, sir.
Okay, again, one more thing to add. In inspection, see, what were the initial differential diagnosis that was told to you? Initial thing?
So growing
something that are even reducible but not related to hernia. What was the thing?
Saphina varix, sir.
Saphina varix and one more was mentioned, no?
Yes.
Varicocele.
Varicocele.
Varicocele. So by inspection itself, can you make out any difference in this varicocele and hernia? Something in particular?
Yes.
Inspection wise. Any appearance? See, sir asked in the scrotum itself, usually this varicocele, they will have, especially it will be a class 3 or a class 4, a grade 3 or a grade 4 varicocele will have. So they will always have what you call the appearance of high tortuous areas. Okay, tortuous areas. So, and that on lying down, as this sir mentioned, on standing, there will be increased this sort of these varicosities will appear. Once you lie down, these varicosities will disappear. That's one of the major things. And similarly, is there anything related to Saphina varix? Saphina varix?
Its location, sir, it's little laterally.
Yeah, location and also impulse. See, impulse on impulse on cuffing. No, impulse on cuffing. See, always hernia will have, because of the sac that the hernia has got, there will always be an expansile, no? Expansile and then bulge out. But what regarding Saphina varix, there will be only a pop-up or just a bulge, and which on lying down can reduce also. Okay. So by that also you can immediate differential diagnosis of these reducible swellings apart in the inguinal area or groin area apart from hernia, you can differentiate by inspection itself.
Yes.
Okay.
So Rafael, what we are trying to tell here is that instead of trying to tell the position of the penis central or something like that, what is important as a surgeon for you is to get an idea whether it's a bubonocele incomplete or complete. So you have to examine up to the testis point has been very clearly told. Plus, if this patient has, if you don't see the testis, is it possible that patient can also have a hernia? Testis is not seen at all. Testis is not developed. I am giving a clue to you.
Sir, it can be
Yes.
ectopic
So,
undescended testis.
so it can also be associated with hernia. So what I'm trying to tell is have a look at everything clearly. You understand, no?
Okay, sir.
You have to mention testis is seen or not seen, bilateral, whatever it is. And penis and that phimosis, and that has been already clarified. Expansal impulsion cough you should mention. And later you palpated this and I saw reducible. Then you checked for palpation and asked the patient to cough. In the deep ring occlusion test, what did you find in this patient?
Deep ring occlusion test was negative, sir. It came out after occlusion of the deep ring, sir.
Negative means what did you find?
Sir?
What is negative? I don't know what is negative.
What sir trying to tell, don't say negative, positive.
Sir,
if you are advocate of direct hernia, will say this is positive for direct hernia.
Sir,
So say finding is deep ring occlusion suggests hernia is direct.
Oh, okay, sir.
Okay. But there is a one question. I think, is it clear to you, sir, is definitely what is meaning of expansile? Just clarify it. I would like to know what does it mean? What do you understand by expansile?
Sir, swelling increases in size in all directions.
There is an actual increase in size of swelling.
Yes.
Maybe 1-2 direction, right? Which other type of impulse is there?
Uncle.
Hello.
So I just, so again adding on, if you don't, when you ask of, you will say swelling. If already a swelling is there, it becomes bigger in size. Is it clear?
Yes, sir.
That is what is the meaning of that. What I want to answer in the deep ring occlusion test is in the universities, swelling is seen or not seen. Simple words.
Yes, sir. So, swelling appeared, sir. Swelling is seen, sir.
Swelling is seen. So obviously examiner will ask you, what do you think? Then you say it is a direct hernia like that.
Yes, sir.
Suppose you don't see the swelling, you still make the patient to stand. Why is that?
Sir,
If you don't see a swelling, it is mostly indirect hernia, correct?
yes.
Still you make the patient to stand. Why is that? And make the patient cough. Because you want to rule out other hernias, including femoral. Is it clear?
Sir.
So you have to be very careful about it. So you should not be happy if you don't see a hernia occluding. When you occlude the thumb, occlude the deep ring with the thumb, if you don't see the swelling, you will think it is indirect hernia. Correct. I am not denying that. But you make the patient to stand, preferably. Again, ask the patient to cough. You are also inspecting the femoral region. Is it clear?
Yes, sir. Okay, sir. Yes.
Sinoy, sir, actually, there is some difference here. We always teach our student that deep ring occlusion test should be performed in standing position only after blocking. That's what we are teaching, not in lying down. So the reason is that maximum pressure is elicited when the patient stands.
Sir, one small thing here. One of the main requirements for a deep ring occlusion test is reducibility.
Yes, obviously.
So you have to make the patient lie down, reduce the swelling,
and then block it and ask the patient to cough, stand and cough like that. That's what, yes, sir.
Occlude with the thumb.
So my contention is these tests are not done anymore. They don't help. And I mean, they're just theoretical.
Yes.
So it's fine, you can ask, but then I wouldn't question if the candidate says yes or no or doesn't know about it.
No, sir, I would like to differ here. It definitely makes difference as far as anatomical part is concerned. I would like to know, how will you find deep ring?
Yeah, I mean, that's okay.
Because that's the way he will know that. How will you find deep ring to occlude?
Sir, deep ring is located at the midpoint of the inguinal ligament around 2 to 3 centimeters.
Wrong.
No.
2 to
That's
3
what the problem
centimeters.
with the students are.
Okay, Dr. Roffel. First,
Yes,
let me ask you, why do you want to know where the deep ring is? Let's forget the deep ring occlusion test. Why do you want to know where the deep ring is?
Pardon, sir, I don't get the question.
Dr. Roffel, why do
Yes,
you
sir.
want to know the position of the deep ring, the surface marking of the deep ring?
Sir, in order to put the incision for surgery, sir.
Yes, when you want to make an incision, it would extend from pubic tubercle to just
the
beyond
deep
the
ring.
deep ring.
Yes, sir.
So now you tell us where the deep ring is.
Sir, I read in the Bailey, sir, it is given at the midpoint of the inguinal ligament, 2 to 3 centimeter above and just marginal to the femoral pulsation.
Okay, fine. Now, what is mid-inguinal point then?
From pubic tubercle to ASIS, sir.
Pubic tubercle to ASI. Look, the inguinal ligaments extend from where to where? From the ASIS to pubic tubercle.
Yes, sir.
And then the fibers, they extend over it, right? Some fibers extend over the pubic crest, and some fibers go behind, forming the lacunar ligament.
Yes, sir.
Right? Okay.
Doctor,
So
Dr.
if you
Arun Pandey, please mute yourself, please. Dr. Arun Pandey. Lot of noise.
So if you have the midpoint of this point, what would you call it?
Sir,
The mid-inguinal point. Midpoint of inguinal ligament. Okay. And if you take it from the pubic symphysis to the ASIS, that would be the
mid-inguinal
point, right? So one, you have the internal ring, the other, you have the femoral artery lying below.
Yes.
Right? So
Yes.
if you take a deep bite at the mid-inguinal point, you may injure the femoral artery.
Yes.
That's the importance. Okay. Now you tell so. Yes, sir. Please go on.
Please. Still, I am confused. What did you actually say? Is it a midpoint of inguinal ligament or mid-inguinal point? Deep ring situated. Dr. Rafael?
Hello, sir. Sir. Midpoint of the inguinal ligament.
No, I would say it is a mid-inguinal point. We measure from pubic symphysis to ASI, exactly midwell. Go and see the patient. Forget about Bailey, whatever the Bailey has written. Go and see. Find the midpoint from pubic symphysis to ASI. Exactly behind you will find the femoral artery.
Okay, sir.
So it's a mid-inguinal point. Midpoint of inguinal ligament is a different. It will be little lateral to that actually deep ring.
Okay.
Right? So why your sir has already asked, right? Why is it necessary to, because in today's scenario, we don't do it. Sir is right, absolutely, whatever it is. But can it help to know preoperatively whether it is a direct hernia or indirect hernia?
Yes, sir. I can do the ring occlusion test.
No, that's fine. But knowingly means you have done the ring occlusion test, you found it to be direct hernia or indirect hernia.
Yes, sir.
How will it help in your management?
Sir, there is no difference in the surgery for both, sir.
There is a difference, definite difference, lot of difference.
Yes.
So what are the parts of surgery you know? We are talking of supposedly open. What are the parts of the hernia surgery?
Sir, first the reduction of the contents.
Okay.
Then if there is any...
Suppose there is a direct inguinal hernia, what surgery you will do?
So herniorrhaphy or hernioplasty, sir. Hernioplasty.
Or there is nothing mesh, like or.
Hernioplasty, sir. Mesh.
Okay. If there is an indirect hernia, which type of surgery you will do? Same surgery or is there anything else you will do?
Now,
you understand my question or not?
Yes, sir.
So it's the same surgery you will do. Lichen is a part that is known as a hernioplasty.
Yes,
so
sir.
do you need to do anything else apart from that? If it is an indirect hernia? This is a very basic question.
Sir, I will open the sac and...
What do you call it? What do you call it?
Herniotomy.
What is the name of that procedure?
Herniotomy.
Herniotomy. If the hernia is direct, will you do herniotomy or not?
Yes, sir. Yes, sir.
In all direct hernia, you do herniotomy.
So, large ones, sir.
All, I have used word all.
No, sir.
You don't do it. You don't do it. Right? Understand? So in direct hernia, most of the time we do not open the sac.
Yes, sir. Okay, sir.
We simply put a mesh, or it is little larger, you can do plication and put a mesh.
Yes.
So in direct hernia, most of the time herniotomy is avoided. Second point, what I want to say, what is the position of cord in a direct hernia and in indirect hernia?
In indirect hernia, sir, hernia is along the cord, sir.
It is covered by which layers?
External spermatic fascia.
No,
Cremasteric,
no external spermatic fascia in canal.
Cremasteric and internal spermatic fascia.
Internal spermatic. So where will be the cord and sac?
Inside the cremasteric.
Inside the internal spermatic fascia. If hernia is direct, where will be the cord?
Sir, it is outside the cord.
Yes. So it definitely helps to know most of the time if hernia is direct or indirect.
Yes.
So you should understand, yes, your diagnosis or your finding may be wrong. It doesn't matter, but you should know how to perform that test. Please, sir, carry on.
Rafael, one more thing. See, in the consistency, you have mentioned as Dowie consistency. What do you mean by that? Consistency?
Sir. It is the consistency of momentum, sir.
So what are the other consistencies you can get?
Sir, it can be soft or elastic in consistency in bowels.
Elastic in bowel? I don't think so.
Soft.
Sir, that elastic in bowel is given in the erstwhile DAS, sir. I think that somehow or other that elastic consistency, nowhere else it is used, but it is given in DAS, sir. Maybe seniors here can advise. There is a publication telling when there is a bowel inside, it has to be mentioned elastic. I think the candidate is right, sir.
Okay. Okay.
Go ahead, sir. Go ahead.
Okay.
Shanai sir, what is your take, sir? Kanna sir, Shanai sir.
I think elastic is okay. That is a word given in almost all the textbooks here.
Yes, sir. Sir?
Okay, Doctor.
Jaya sir, please tell me something.
Right. You said no Malgagny's bulge. What do you mean by Malgagny's bulge?
Sir, it is usually seen in the lateral bulge due to the deficiency or of I can get the term, sir. Due to the abdominal wall muscles, sir. Weakness of the abdominal wall muscles.
In the flanks. Okay, it's seen in the flanks.
Flanks, sir. Flanks.
Right. So what does that tell you? What does that tell you?
It can be due to the weakness of the abdominal wall muscles.
That's fine. So what does it, as a surgeon, why are you concerned?
Sir, the patient needs strengthening of the posterior layers.
Right. So you have to do this surgery, you have to use some processes.
Yes, sir.
Right. So he will require some process for surgery. Okay. Let's go to your last slide. Next slide, please. So percussion is out. I don't think you can percuss a hernia or a hydrocele.
Okay.
Okay. Last slide. So what's the diagnosis now?
Sir, it's a left-sided direct inguinal hernia, which is uncomplicated and omentum as condensed.
Left-sided direct inguinal hernia, uncomplicated with omentum as consent. Oh, you think, why do you think it's a left-sided direct inguinal hernia?
Sir, in deep ring occlusion test, it came out, sir.
What's it?
Can you tell what are the fallacies of the deep ring occlusion test?
Sir, if deep ring is patulous or widened, again it can get positive, sir. And it
Okay, let's go to your management. How will you manage this patient? It's come to you. You think it's a direct inguinal hernia.
sir. Sir, anyway, sir, I will plan for surgery. So I will have to do the routine investigations.
Straight away for surgery. You want to tell him?
Sir, routine
Straight away
investigations.
for surgery. No, hang on, Dr. Rufal.
Yes, sir.
You'll tell him straight away, I'm going to operate on you. How will you counsel this patient?
Hello, sir. Sir.
Suppose the patient says he doesn't want surgery.
Yes, sir.
Then what do you do?
Sir, only I will advise lifestyle modification only, sir. Then monitoring.
What lifestyle modification? No.
So I will
You
ask.
have a patient in your OPD, Dr. Rufal. You have a patient
sir.
in your OPD. He's this patient.
Yes, sir.
You think he requires surgery? You tell him we have to do a kind of surgery. He says, no, I don't. Can you do something without surgery? What will you do? Tell him.
Sir, truss is an option, sir. But
Tell him modify your right side.
Hello, sir.
Will you tell him to modify his lifestyle? What lifestyle modification will you ask him to do?
Truss is an option, sir, but it is not recommended now because
You're just saying it's an option, but it's not done. So what will you tell him?
Sir. Then I will ask him to avoid stop. If he is a smoker, I will ask him to stop smoking. And
he's not a smoker. Your patient is not a smoker.
Yes, sir.
How will it help?
You will tell him.
He's already developed hernia.
Sir. And it will further increase in the size, and if he is
smoking will not further increase the size. You will have to convince him that he needs surgery. Now, how will you convince him that he needs surgery?
Sir, is for hernia, sir, surgery is the only option. There is.
How will you convince? I'm not convinced here. How will you convince him that he needs?
Question. Think laterally. If patient doesn't get operated, what will happen?
He may develop complications, sir.
Yes. See, you will have to explain that to the patient. No?
Okay,
They will be willing.
Yes, sir.
So what complications?
Yes.
Sir, it can be irreducibility, obstruction, strangulation.
You'll tell him all this. Reduce strangulation, obstruction.
Your diagnosis
it all
is a
go
direct
with
hernia. Complication you are expecting?
Yeah, it's a direct hernia.
Your case is a direct hernia, no? You are expecting an obstruction?
No, sir.
Then you are talking about with your case. And the term itself, what do you mean by uncomplicated direct hernia?
Sir, there is no features of any obstruction, irreducibility, or strangulation.
You are not expecting an obstruction in a direct hernia. Then why you want to put it as a uncomplicated?
Yes.
Okay, now,
So
sir has asked how is the patient of the surgery?
Yeah, convince him. He's got a direct inguinal hernia. Uncomplicated, nothing. Small one.
I am surprised that today you brought the word trust for a 46-year person. I think you should never have done.
Yeah,
that you should not have opened that at all. Okay.
Yes,
That is,
sir.
I think, better
there's a noose hanging for that, for you. If you mention trust, the examiner will carry a noose along for you.
Because I was very much tempted to ask, what are the types of truss you know?
Okay.
What is the biggest complication of truss?
Dr. Rufal, now that we've raised the topic of trust.
It's okay, sorry.
So,
but you remember,
yes.
Truss is only to be mentioned to condemn. That's the word which has been taught. So best for you is never utter word truss.
Yes.
Don't even to that condemn it. No truss, nothing doing. The point is that what sir wants to know is that you should be able to convince the patient that if you do not get operated, this can happen in some emergency and you may have to rush. At that time, there will not be time to breathe because hernia complication is like that. That the patient will be convinced only when that you will have to rush in emergency. That's it.
For a direct hernia, the most common thing would be that it will keep on increasing in size.
Size.
Yes.
As his age increases, the muscles become weaker, and the chance of recurrence becomes higher.
Yes, sir.
Right? Right.
Okay.
Sir, Dr. Pankaj.
Yes. What surgery you will offer to the patient? This is your patient.
Yes. Dr. Rofel, are you there?
It's a very simple question I'm asking.
No, I think it's lost him.
We
lost
lost.
him.
Yes, it looks like that. Ah, yes. He is
Yeah,
there.
okay.
Hello, sir.
Dr.
Yes.
Rofel,
Dr. Rofel,
Yes.
sir.
question was, what surgery you will offer to this patient, your patient?
Sir, I can offer either open or laparoscopic surgery, sir. I will offer mesh hernioplasty, sir.
Hang on. You'll offer him open or laparoscopic surgery.
Yes.
Right? So he says, I want laparoscopic surgery.
Yes.
So what will you do now? What kind of laparoscopic surgery will you do?
Total extraperitoneal.
Okay. How many have you done? How many have you done, Dr. Rofel?
No, sir.
You have not done. So how can you offer that thing to him? But he insists that I want to get a laparoscopy, Dr. Rofel. He says, I want nothing but laparoscopy, and you don't know laparoscopy. So what will you do?
I only can refer, sir.
No, you don't refer. You call for help here. No one
Yes.
refers. In private practice, no one refers here. You
Yes.
call for help. You ask someone to help you out in your laparoscopic surgery.
Okay, Dr.
Okay,
Rofel,
sorry.
what is gold standard in hernia surgery?
So mesh.
The mesh is fine.
Sir.
Open or laparoscopy?
Laparoscopy.
No, open. Even today. You understand?
Yes.
Yes, but laparoscopy is there. It's up to patient and surgeon to decide. So what is the biggest disadvantage of laparoscopy surgery in hernia?
Disadvantages, sir.
Advantage is everybody knows.
Yes.
Why still it is not accepted as a gold standard?
Recurrence rate, sir. One.
Yeah, that's the one is a recurrence rate. That is a very important. Because in today's scenario, hernia surgery, the success is measured by minimum recurrence. So what is the recurrence in an open like a Liechtenstein, and what is the amount recurrence in laparoscopy?
Open Liechtenstein is around 5%.
5%?
1 to 5%.
Huh? 5% is too high. Even
Sir,
that is not in laparoscopy.
Less than 1%.
You sure 0.4% it is supposed to be. And in laparoscopy, it is again depends upon the operator by operator, but minimum 2% it is said. That is the basic difference why the people are. But anyway, you are right. You should offer either of them. But if you take my advice, open surgery is equally good for a discussion.
Okay. So,
Please,
yeah, one more thing. See, you have mentioned that this has a left-sided direct inguinal hernia. Two things in that area. See, what will be the NIHS class in this patient? NIHS classification?
Class 3, sir.
Yeah, it will be?
NIHS class 3.
Class 3, what? Again, 3 is divided into A, B, and C, no?
Sir. Class A.
Yeah, 3A.
Yes.
See, and see, if you are offer some, see, the patient is asking, see, do I need to do some more imaging investigation, sir? So, any other imaging investigation would you consider in this patient?
Ultrasound, sir.
Why? What are you looking for?
In ultrasound, I will look for the size of internal ring, sir, and also any other risk factors like ascites or BPH, prostatomegaly.
So this is a 46-year-old gentleman, no?
Yeah. And
Anything else? He has got no addictions.
yes, sir.
He has got no addictions. But still, now in this age group, between 40 and 50, what is the commonest liver abnormality that nowadays we see?
CLT.
Due to?
Alcoholism.
No. Now it is more of NASH, non-alcoholic steatosis. See, always we take an ultrasound abdomen, not only abdomen as well as the inguinal area, not only to assess the contents and everything, but nowadays we also need to assess the liver. Okay, because fatty liver and non-alcoholic steatohepatitis is on the high rise.
Yes.
So if we want to treat, maybe that itself may be a triggering factor. Okay, so we have to treat that condition also concomitantly.
Okay, sir.
Okay. Now, what is the indication? Any indication for taking a CT in hernia, inguinal hernia? What are the indications for taking a CT in case of inguinal hernia?
Sir, if you are planning any abdominoplasty or to look for the abdominal wall muscles.
Not abdominal. Yeah, abdominoplasty. Inguinal hernia. In relation to inguinal hernia, what are the indications?
Muscles to look for
CT.
yes, sir.
See, basically for recurrent 2, second recurrence, third recurrence, and all, as Afar mentioned, one of the major things in relation to laparoscopic repair is again recurrence. So definitely you can take a CT not only to assess whatever is happening in the inguinal area, but also to assess which is the plane in which the previous surgery was done or previous mesh was placed again.
Okay.
Okay, see, that is also very important when we consider a contrast enhanced or CT in the case of a hernia. Now, what is Gilmore's hernia? Gilmore hernia?
Sportsman's hernia, sir. Athletics hernia or sportsman's hernia, where there is patient is having severe pain in inguinal region, which can be due to pubic diastasis or a tear in the muscles.
No, commonly seen in sports person. What do you call those sort of hernia? Maybe clinically it won't be there, no? What do you call those sort of hernia? Occult hernias. See, occult hernias also. Okay, sir.
Just one or two things from my side. Apart from the ultrasound, which has been told to you, 2 reasons why we should do ultrasound. Today, one is all the documentation of inguinal hernia. Number 1, for the insurance or whatever purposes. Number 2, when you have a early bubonosir, where a doubt is there, some patients complain of groin pain. So ultrasound is an excellent investigation if they're just to know the early part of the processes vaginal sac entry. That is one.
Okay.
Now, in addition to what has been already mentioned, role of CT scan. What is sliding hernia?
So sliding hernias is like hernias with bowel or bladder as a wall.
No, 1 minute. Yeah, bladder, and maybe yes. What is sliding hernia? The whole posterior wall, that slides. Maybe cecum can slide down. So such definitely cases where injury to the sigmoid colon, cecum, bladder, all this can happen. So whenever such kind of a hernia encounter, to know the anatomy better, we advise CT scan. And lastly, that Gilmore's groin, which has been discussed just now. What is the investigation of choice in that kind of a cases where you suspected groin pain for evaluation?
MRI, sir. MRI.
So that is how, these are some of the standard, questions. Okay, thank you, sir.
Sure. Should we call it a day? Next presenter.
Yeah. I think
so.
Only
yes, sir. Please, sir.
nothing. I feel that Lichtenstein's hernioplasty, I think you should know how exactly to do. Okay.
Yes.
Especially a case like this where the unilateral small hernia, the question was asked, no, TEP and all that thing. So unilateral small hernia confined to that area, definitely it has to be operated. So you can always mention that you will do a Lichtenstein's hernioplasty, and you should know the steps of it properly.
Okay.
Where exactly you suture above to the transversalis fascia, below continuous sutures to inguinal ligament, laterally you have to. What do you do with laterally? Laterally,
Exactly. Overlap the sir 2 folds and we suture to the posterior walls.
laterally you use some cut, no? Cut. What is it?
Fishtailing, sir.
So you have to mention, no? Cord has to be brought out there. And then medially it should be overlap there. So medial direct recurrence can happen, especially indirect hernias. And mesh should not be too tight, suturing. It should give a dome-like effect. Let it not look very beautiful, doesn't matter. But if you are too tight, if you suture, why you should not put it too tight? Like a flat, if you keep, what will happen?
Medial recurrence is due to the
Mesh shrinks. So that also you should know. So size of the mesh is important. Overlapping is important. And too tight should not give rise to edema, cord edema, then
yes.
inguinal, the pain, etc. All that thing. So these are some precautions. I think the time is catching. Thank you.
Thanks.
And we have Professor Srikumar also with us. Professor Srikumar, sir, would you like to give comments or we'll move to the next case, sir?
Dr. Kanakwal, I would like to say one or two things.
Please, sir, please, sir, please.
Basically, the problem in hernia, one thing is that it is a short case most of the time. It doesn't come as a long case. So be more precise in describing it and develop a habit to describe inspection and palpation together.
Yes, sir. Okay.
Second point, you should know very detailed anatomy of inguinal canal. There should not be any confusion about the anatomy. What is because there can be a simple question, what is groin? And you will be in trouble if you do not know. What is groin?
Groin is the area, sir, where thigh and abdomen is in contact, sir, when we are folding, flexing
the point here is you should know exact definition. 2 centimeter above and 2 centimeter below the inguinal ligament is considered as a groin. So this is the way. Anatomy, you should concentrate more when you are discussing inguinal hernia. Thank you. Thank you, sir.
Thank you, sir. Dr. Rafal, do you have any doubts to clarify?
No, sir. Okay.
Thank you, Dr. Rafal, and thank you, Dr. Anil and Dr. Srikumar, sir, for kindly providing Rafal here. Now, with the permission of the faculty, we move on to the next case. Dr. Ishan, we have Professor Ibrahim, sir. He is a surgical oncologist, has kindly consented to join us for this class. Welcome, Ibrahim, sir. And Dr. Ishan, please introduce yourself, your unit chiefs, and then your head of the department and start your presentation. Good luck to you.
Yes, sir. Good evening, sir. Myself, I'm Dr. Ishan.
1 second, Ishan. Dr. Rafal, can you please unshare your PPT? Now you can share, Dr. Ishan.
Yes, sir. Just a second, sir.
JLL, sir, returning back to Kanyakumari, sir. Sir, you are in mute mode.
No, we are going for a party.
Okay.
We are. Myself and Balagan sir are going out in Madurai.
Yourself and Balamurugan.
No, I was in Poppies. Now we are going out.
Balamurugan, sir, good evening, sir.
No, he's coming in another way. I'm going there. Okay.
Bansal, we are waiting
So you
for
are reaching here tomorrow morning,
sir.
no?
Yes, sir. Yes, sir.
Morning,
Sorry,
I'm available,
sir. Just a second, sir. The application is asking me to. Okay. No, no. Okay. Just a second. Yes.
Yeah, you are good to go, man. Good luck to you.
Thank you. So good evening, everyone. I'm Dr. Ishan Bansal. I'm a junior resident in Department of General Surgery from Government Medical College and Hospital, Sector 32, Chandigarh. So my unit head and the head of the department is Professor A.K. Atri. And I'll continue with the presentation. So my case is a patient is Rashpal. He's a 52-year-old male, resident of Punjab and a shopkeeper by occupation, who presented to us with chief complaints of loss of appetite for 4 months, vomiting for 3 months, and passage of black tarry stools for 3 months. So the history dates back to 4 months when patient was apparently well and noticed loss of appetite, which was insidious in onset and was progressive. It was accompanied by vomiting after meals for the past 3 months, which was non-bilious, non-blood stains, cupful to glassful in quantity, containing eaten food contents. Initially, the vomiting it occurred 2 to 4 hours after taking meals, but this duration it gradually decreased over past 3 months to 15 to 30 minutes at presentation. So it was aggravated by intake of solid food, but not to liquids. There is history of passage of black stools for the past 3 months, which is semi-solid in consistency, without any evidence of passage of clots or fresh blood. This was associated with alteration of bowel habits, likely due to change in eating habits. There is history of significant weight loss of 8 to 10 kgs over the past 4 months. There is history of generalized weakness over past 2 months. There is no history of any abdominal pain, fever, or yellowish discoloration of skin. There's no history of any difficulty during swallowing. There's no history of shortness of breath or cough. There's no history of any bony pain. There's no history of any headache or blurring of vision. So regarding the treatment history, patient in these 4 months, he took over-the-counter medication and multivitamins on and off for vomiting and for appetite, but for little to no relief. Then patient went to a local hospital for consult 2 weeks ago and was advised upper GI and CT, which patient got and presented to our OPD. So in past history, there's no history of any chronic illness or past surgery. In family history, there's no history of malignancy in the family, and the patient has 6 siblings, all in good health. Regarding personal history, patient is non-vegetarian by diet and not a smoker or alcoholic. So to summarize, the patient is a 52-year-old male without any comorbidities, presented with loss of appetite that gradually progressed to vomiting after meals, which was associated with passage of black starry stools for 3 months without any history of abdominal pain or during the present illness or in the past.
Okay, Dr. Ishan. What do you think is the history suggesting you?
Sir, since he's a 52-year-old male,
Loss of appetite, vomiting after meals,
yes,
black
sir.
tarry stool, right?
Yes, sir.
Nothing else? Loss
No,
of weight.
yes, sir, loss of weight is there.
So that is, look, in your summary, you should mention the important positive points.
Yes, sir.
Right. Okay, so what do you think it is?
Sir, according to the history and upper GI bleed, significant weight loss, it's pointing towards upper GI malignancy, sir.
Upper GI malignancy. Why do you think it's upper GI? Malignancy. Why do you think it's malignancy?
Because, sir, the patient the age is 52 and he's having a history of 4 months, and there is a history of weight loss as well that is significant. So those things they point towards a malignant etiology.
So a normal condition can have black tarry stool also in 4 months.
So patients,
Benign condition.
yes, benign condition, sir, in peptic ulcer disease, the patient may have sir, upper GI bleed, sir.
Okay, may have. Can it be any benign condition which is leading? You said peptic ulcer disease. Can it present this way?
Sir, it will present with upper GI bleed, but without pain, sir, it is very difficult, sir. Without pain, because the pain is characteristic for peptic ulcer, sir. And in this patient, sir, there was.
But you said meals associated with. What does that? Is that pain? What he's saying? Passage. Okay, there's no pain.
No, sir. There's no pain. The patient complained of no pain, sir.
Okay, let's go back to your history now. First slide. You think it's upper GI malignancy. What are the risk factors for upper GI malignancy?
Sir, upper GI malignancy, it could be intake of smoked.
Okay, let's start off with it. What do you mean by upper GI?
So upper GI is includes esophagus, stomach, and duodenum up till the ligament of Treats.
So you think it could be anywhere from here to here?
No, sir. Because sir, there's no history of difficulty in swallowing, sir. So likely it could be in the stomach, sir. Stomach or
Okay.
duodenum.
So now, what are the risk factors for?
Sir, it could be certain lifestyle issues such as obesity, then sir, certain
Obesity is
food.
not lifestyle.
Yes, sir.
Patient, obesity is not lifestyle.
Okay, sir.
Not lifestyle. Okay, just obesity. You think obesity is the cause for stomach?
No, sir, not directly, sir.
So come up with the most common ones first. Which
Yes,
are the most common ones?
Yes, sir. Some smoking and alcohol intake, sir, and
Okay.
intake of smoked meat products, sir, and
Alcohol, tobacco. Obesity is there also. It's there. Alcohol, tobacco, and low physical activity. These are the lifestyle goals, right?
yes, sir.
And then you have occupational. Do you have any malignant conditions? Precursor conditions for CS stomach. What is CS stomach usually associated with?
Sir, CS.
Any precursor condition? Any kind of infection?
Yes, sir. Sir, yes, sir. H. pylori, sir. Yes, sir.
H. pylori. Any other things? What's Barrett's esophagus?
Yes, sir. The Barrett's esophagus is the intestinal metaplasia of the squamous columnar
Right.
junction.
So you have to. What are the other common ones, which are precursors for malignancy? Any kinds of gastritis?
Sir, atrophic gastritis. Yes, sir.
So you you can't help have me prompting you all the time, please.
Yes, sir.
Others, you must rattle. Look, you're going to get a case of CS stomach in your exam. You must be rattling off to me, and you must be prepared for this. So you can't go on like this.
Right, sir.
Sir, please, sir.
So, Bansal, going back to the history, can you go to the first slide, please?
Yes, sir.
Yeah, first slide. Yeah, first slide. Rashpal name, age. Yeah. So, any risk factor you are associating with Punjab, resident of Punjab?
Yes.
No, sir.
No.
Okay. Punjab has got a cancer belt around. They've got a train running from Punjab to some place.
In fact, it is very much contributory to you. Okay. So, shopkeeper by occupation. What is helping you in this sentence? Shopkeeper by occupation. Any assistance?
Sir, no, just I wanted to get a background of what the patient does, sir, on the daily life, sir.
No, for whether it is helping you in your diagnosis. So see, a clinician or a PG student or whoever is taking the history, what is the idea of taking the history? The history should contribute to a diagnosis, a clinical diagnosis, okay? And history is not a flow chart like thing. And then anybody can take, even an artificial intelligence or even a mobile phone can take. So the idea of taking history is where all we have to examine. What are the things we are going to examine? So it should guide us. Yes, so Rashpal, male gender, is it high risk?
Yes, sir.
Yes, so it is high risk. Okay, next 52 years, old male.
Yes, sir.
Right. Resident of Punjab. As sir told, it is a malignancy belt. Okay. And shopkeeper by occupation, irregular diet. He's going to take irregular diet and time food, right? Yeah.
Right.
Go to the next slide, please. So there is loss of appetite and vomiting and black tarry stools. Okay. So loss of appetite. Why does loss of appetite happens?
Sir, loss of appetite, it can happen as the tumor, it decreases the capacity of the stomach, sir, the volume of the stomach.
So is that the answer? Now, where do you think
That
the
would be
tumor
early
is?
satiety. That would be early satiety if there's something occupying the stomach.
Yeah.
Loss of appetite is something else.
So where do you think the tumor is? It is in the entire part of the stomach. It is like a liminitis plastica, or it is in the proximal or in the distal. Where do you think it is with the history as of now?
Sir, it appears to be sir, distal, as there is vomiting that is occurring, sir.
So what happens in the distal? What happens?
In distal, sir, there is gastric outlet obstruction, sir.
So
The stomach, so after eating, sir, once the stomach is full, sir, the patient has the food, it is not passing down the pylorus, sir. So patient will vomit it out, sir.
So there is always a satiety is there. The stomach is always full. The stomach cannot empty. There is
Yes,
no
sir.
gastric emptying. So that's the reason why there is a loss of appetite. So, so you tend to say this loss of appetite is there for 4 months and vomiting is for 3 months. So which symptom you think will be the first one? The loss of appetite or the vomiting? Of the 3 symptoms you have told, black tarry stools, vomiting, loss of appetite, which you think might be the first one?
So the first one, sir, should be sir, vomiting, sir.
No. So so vomiting is caused by a physical obstruction, right?
Yes, sir. Yes, sir.
So what is the reason for black tarry stools?
So I'm sorry, sir. The tumor itself, it may, sir, ulcerate and it may bleed, sir. So
No,
that
no,
will
it's not may. It will definitely bleed.
Yes, sir.
So that is causing black tarry stools because there is upper GI hemorrhage.
Yes,
So
sir.
even before there is an obstruction, gastric obstruction, there will be definitely some bleeding. So usually
Okay,
the
sir.
black tarry stool precedes vomiting. Vomiting precedes loss of appetite.
Okay, sir.
That will precede loss of weight.
Right.
So this
Okay.
will be the thing. So always keep this loss of weight and loss of appetite as the last one.
Okay.
And most of the time, the patient will not come for loss of weight or loss of appetite to a clinician. So most of the time, they will come for only 2 things in GI.
Yes, sir.
It is pain and vomiting.
Right, sir.
So that is the most important symptom. Okay. So even though the patient may be telling us 4 months, 3 months, or whether you have written like that, you should change it or put it in the proper chronological order.
Right, sir.
Right. So now go to the next slide. So
In fact, Doctor, sir, sorry. Sir,
Yes,
please,
sir.
sir.
Yes, sir. Okay. So history dates back 4 months ago when patient was apparently well and noticed loss of appetite, which was insidious in onset and progressive. Okay. So you have explained about loss of appetite first. Okay. So ideally it should have been in the other way. So aggravated by intake of solid food, but not to liquids. Why do you think this is happening? Aggravated by solid foods and not to liquids. Why is this happening?
Sir, I think this point, sir, the obstruction is not complete, sir. So I think some liquid the patient, when it is taking, that they are able to pass through, sir.
Okay. And regarding the vomiting, so the most important thing that you have mentioned, so it is non-bilious, non-blood stained. Okay.
Yes.
So here, if the patient is passing black tarry stools, right?
Yes, sir.
There is bleeding.
Yes, sir.
But you have also mentioned non-blood stained.
Yes, sir.
Is it not contradictory?
Yeah, I thought so, sir. But according to patient, he never noticed any blood and vomitus, sir.
So which is very easy to find? A vomiting, there is a hematemesis or a black tarry stools? Which one is easy to find?
Sir, vomiting, sir. So blood and vomitus.
So blood in the vomiting is easy to find. Right. So why does this black tarry stools happen?
Sir, as the blood, sir, it is from the upper GI bleed. The by the time it is passed out, sir, it has broken down into heme, sir. So
Broken down into?
sir, broken down into, sir, hemocidin and sir, basically, sir, the breakdown products.
Look, Dr. Bansal, you have prepared this case as a gastric carcinoma.
Yes.
These are questions which are bound to be asked. What is black tie? What is the cause of it? You should be able to come up with the right answer immediately. You can't say hemocidin.
Yes, sir.
Sir, please, sir.
Yes, sir. Thank you. So, Bansal, when did you take the case?
Sir, it was taken sir, 2 weeks ago, sir.
2 weeks ago. When did you prepare the slides?
Sir, last week, sir.
Last week. Okay, fine. So you prepared or somebody else?
Sir, I prepared.
Okay, fine. So it is actually acid hematin. Okay.
Okay.
So acid hematin produces the black color. It is not hemocidin as I told. And
Yes.
so from where the acid is coming?
Acid, sir, it is coming from the gastric secretion, sir.
From the gastric secretion, right? So when the gastric outer obstruction is there, can the acid pass through?
Sir, like in this case, sir, it is not in complete obstruction. So, sir,
So if it is a complete obstruction, what I'm asking is if it is a complete obstruction, the acid cannot pass through the gastric
Yes, sir.
outlet. So it cannot
Yes.
pass the pylorus, right?
Yes,
But
sir, right,
a part of the tumor which is distal to the pylorus will not be reacting to the acid, which will not be exposed to the acid, right? So
Right, sir.
if there is a bleeding, it cannot react with acid. It's going to be an
Right.
alkaline media. So in that case, will you be able to see an acid hematin or a black tarry stools? Are you able to get my point?
Yes, sir, I get your point,
So
sir.
always this acid hematin formation, black tarry stools, everything precedes vomiting, loss of weight, loss of appetite.
Okay, sir.
Got it? And okay. And regarding this 2 to 4 hours, why is there is a delay? 2 to 4 hours. What is the reason? Maybe there.
Sir, initially, sir, there might be that the obstruction was partial, sir. So some of the, sir, food it would go, but as the duration of the disease progressed, sir, so gradually there was a build-up of food that ultimately it causes the decrease in the time interval between the.
Okay, okay, I'll come to as you are thinking. So when there is a obstruction for a longer period, what happens to the stomach? Does it decrease in size or increase in size?
No, sir, it increases in size, sir.
It increases in size. What is that called as? If any structure expands, what is it called? Or dilates?
Some Migueli, sir.
Gastric dilation. It is gastric dilation, chronic gastric dilation. So you see the stomach is enlarging. So in which part of the stomach it enlarges? Proximal, distal, lesser curve, greater curve. Which curve expands or which curve enlarges?
The greater curvature, sir.
Greater curvature. So how you might have mentioned, you might have prepared for the clinical examination also, I guess. I hope. And so usually in the normal history there will not be any change in this kind of decrease in the change in time. In fact, it will sometimes increase, okay, because there is a dilation. So chronically it dilates, but the patient will be having loss of appetite and loss of weight, right? So he'll be taking lesser and lesser amount. So the vomiting will not be there so frequently. It will be there, but it will not be so frequently. So the most important history here is it's a non-bilious vomiting, not immediately after food intake.
Okay.
Right now, I am thinking this is since his occupation and all these other things, I am thinking it is a benign obstruction as of now. Benign pyloric obstruction happening because of a long-standing pyloric ulcer. How do you refute it? But you are thinking it is malignant, right?
Yes, sir.
Yeah, even in a gastric aortic obstruction happening in a benign pyloric disease, the patient will have early satiety. He will not be able to take food, loss of appetite, so automatically loss of weight. How do you going to refute it?
Sir, in case of sir, benign pyloric stenosis, sir, there could be, sir, there would be history of pain, sir. regarding the peptic ulcer disease. That is conspicuously absent in this case, sir.
Okay. So in which ulcer, whether it's gastric or duodenal ulcer, in which ulcer the pain will be aggravated by food, and in which ulcer the pain will be relieved by food?
Sir, in gastric ulcer, it is aggravated, sir, by food, sir. And in duodenal ulcer, it is relieved by food, sir.
Why is that so?
Sir, in duodenal ulcer, as a result of sir, in duodenal ulcer, the pain it typically occurs at night when the patient has gone to sleep and wakes up at known as hunger grain, sir.
No. You are explaining the characters. What I'm asking is the reason.
Sir, because sir, when patient takes the food, sir, sir, as it passes through duodenum, sir, sir, there is basically sir, influx of the food into the duodenum, sir. So, sir, then which sir neutralizes the sir pain.
You yourself know it is not a satisfactory answer, right?
Yes, sir. Yes, sir.
Okay, let's go to the history. Go to the next slide, please.
Next slide, yes.
So could you give me the answers? It's just because of the acid, right?
Yes.
Which is high, which has got higher level of acid, duodenal ulcer or gastric ulcer?
Sir, gastric ulcer, sir.
You've got a higher level of acid.
No.
So sir was asking about some pre-malignant conditions for gastric ulcer, gastric carcinoma. So what is the most commonest pre-malignant condition? You told something. What is that?
Sir, yes, sir. So atrophic gastritis, sir.
So what goes for atrophy there?
Yes, sir. Sir, that is associated with decreased acid intake, sir.
So there is something
There's
atrophy.
achlorhydria usually.
Yeah.
Right?
Sorry, sir.
Yes.
So it is hypochlorhydria, which
Hypochlorhydria.
goes in for an achlorhydria. So that will promote gastric carcinoma, right?
Right, sir.
So you should know the pathology also.
Right, sir.
Yes. Ishan, see, sir had asked you regarding the H. pylori also, no? See,
Yes,
how does H. pylori actually cause all these issues, or why it is considered as a class 1 carcinogen now?
Sir, H. pylori, it grows in the sir the mucosal the mucosal secretions of the sir the gastric mucosa, and it is a sir a urease producing organism, and it causes breakdown of the natural barrier of the gastric mucosa.
No. Actually, it is not in the secretion. It is actually in the pits. Okay, because it has got flagella. No, it has almost got 4 to 6 flagella. So with that, it goes into the pits. Okay. So basically, now what is this chorea cycle?
Sir.
Chorea cycle.
Cori cycle, sir.
Yeah.
Yes, sir. So that is the urea breakdown cycle, sir.
Yeah. What happens in that basically?
So the urea, it is split into sir the components that I am unable to sir. I'm sorry, sir.
No. See, it is not related basically to urea or something. See, always there is a breakdown. See, what is the hormone that plays the pivotal role in causing all these problems? As sir just mentioned, you mentioned regarding hypochlorhydria, achlorhydria. Gastrin, yes, gastrin. See, that is the notorious thing. See, that is why even if more, see, that is what sir also mentioned regarding how to differentiate between, or what's the importance of differentiating whether it is a gastric ulcer or a duodenal ulcer, all that. Okay, because gastrin plays the pivotal role, which can induce itself these changes leading on to metaplasia, sorry, not metaplasia, the atypical changes in the cells from achlorhydria and hypochlorhydria. Okay, so that is what basically even in relation to your H. pylori infection. Just one question. Actually, we have heard from one of our external examiners. Basically, what type of organism is this H. pylori? It is a what? It is a gram negative organism, no?
Yes, sir. Yes, sir.
Yeah, gram negative lophotropous organism. See, some examiners like that also regarding H. pylori, regarding that. And which are the two genes that are associated with H. pylori that can induce? See, if there is one gene mutation or the other gene mutation, which is the risk factor for developing of malignancy, carcinoma of the stomach itself?
So E-cadherin, sir. CDH.
Yeah, E-cadherin, but what in relation to H. pylori, there are CAG-A and VAC-AG, no? CAG-A and VAC. So which gene mutation is the main risk factor?
So CAG, sir.
CAG, yes. Sir?
Yes, sir. So we are going. I think he need to prepare a lot. So CAG gene is in H. pylori or in the humans? Are you there, Bansan?
Yes, sir. Yes, sir.
Where? You have not thought about that, right?
Hello.
I don't think he's gone in that depth.
Yeah. Okay. So we'll go to the history first. So associated with the alteration of bowel habits due to change in eating habits. Okay, fine. History of significant loss of weight. So what do you mean by significant loss of weight? Standard question only.
Yes, sir. Sir, significant weight loss is unintentional weight loss of more than 10% over 6 months, sir, or
Okay.
more than 5% over 3 months, sir.
So you have given it as 4 months here, right? And
Yes,
how
sir.
do you think these patients will tell about loss of weight? So nobody takes weight every 6 months, right? Even you and me won't take it. So
Yes, sir.
how do you assess it?
Sir, the patient will usually say that he notices, sir, loosening of clothes, sir. That is
Yes.
normally.
So loosening of clothes, and the better way is the attenders will tell. Usually the attenders only will be telling that there is loss of appetite, loss of weight, his ribs are being seen, his eyes are sunken, cheeks are prominent, something like that. And as you told, it is loosening of the clothes. Okay. History of generalized weakness over past 2 months. Why this is happening?
Sir, due to sir decreased oral intake and weight loss as well, sir, patient sir, generally in the sense of weakness, sir.
Okay. So there is one more positive history which may be contributory for you, but we have missed is there will be some visible peristalsis or very visible movement in the abdomen. Okay.
Yes.
So most of the people can see it, visible gastric peristalsis. They may not tell it as visible gastric peristalsis. They will tell there is movement. There is sudden movement in the thing which lasts for 5 to 10 minutes. And after that it disappears. Even attenders may tell it. We can see some contractions in the abdomen muscles and automatically it disappears. Like that they can tell. And you have mentioned some of the negative histories. So you have to mention why you have asked it. So abdominal pain, why you have asked it? It is negative. Why?
Sir, to rule out sir, peptic ulcer disease, sir.
Okay. So do you think that in all carcinoma stomach, there will not be an abdominal pain at all?
No, sir. Sir, there might be pain, sir.
So
Abdominal
when
pain.
and how? When will the pain come and how does the pain come?
Sir, pain is, sir, it is usually there, sir, for continuous type, sir.
No. What I'm asking is, it's a straight question. There is no need to beat around the bush. Just tell if you know. If not, you can tell. Don't know, so that we will not waste time.
Yes, sir. Sir, don't know the exact.
Yeah, okay. So in most of the malignancies, pain is a last or later symptom. The reason why in stomach it is happening is there will be posterior infiltration, right?
Okay.
So if there is a posterior infiltration, it may go to the retroperitoneum or to the pancreas or to the autonomic nerves. Nodal enlargement may be there. So that will infiltrate the retroperitoneal structures and that causes pain. So when you see a stomach, okay, carcinoma stomach patient, it is proven. One carcinoma stomach with pain and another carcinoma stomach without pain. Which will you operate? Which will you think is easy to operate?
Yeah, sir, without pain, sir.
Without pain. So without pain means the posterior involvement will be less. Okay. So now fever or yellowish discoloration of skin. Why do you want to see fever for this patient? Do you expect any of the inflammation or infection in this case?
Sir, fever, sir, could be sir, seen in inflammatory conditions, sir. And
Yeah, what inflammatory condition I'm asking? I already gave the answer. So it may be seen in inflammation or infection. So what symptom, what histology you will expect in these things? So why do you want to know whether there is a fever or not? If the patient is having fever, how it will change the diagnosis? So gastric lesion with fever, give a differential diagnosis. In other words, what other histology you can expect in gastric tumors or gastric malignancy?
sir, lymphoma, sir.
Lymphomas, excellent. So lymphoma can produce fever. So fever is what symptom? A symptom or B symptom?
Sorry, sir. Didn't get you, sir.
No, fever in lymphoma.
In lymphomas.
Lymphomas, we have got A symptoms, B symptoms, right?
Yes, sir.
Okay, you are not aware, I guess.
No, sir.
So these are all theory. We are not here to discuss a lot of theories. We are going to discuss only clinicals. Okay. So it's a B symptom. Fever is there, loss of weight, everything is there. So if fever is there, you can consider it as a lymphoma, right?
Right, sir.
Okay, yellowish discoloration of skin. Why you have asked it, and what is the advantage of being a negative one?
Sir, sir, I wanted to rule out any sir, periampullary lesions that may be there, sir. They are usually associated with the jaundice, sir.
Okay, so okay, we'll go to periampullary then. So periampullary, you are asked about discoloration of skin. What other symptom will be there in periampullary?
Sir, regarding symptoms, there could be yellowish discoloration of skin and sir, other stigmata of obstructive jaundice such as pruritus, sir, and passage of the patient will say complaint of passage of clay-colored stools and yellowish urine, sir.
Okay, fine. So in carcinoma stomach, can yellowish discoloration happen, or it will never happen at all?
No, sir. If there is sir, metastasis or infiltration, sir, sir, it may
Infiltration of what?
sir, it may infiltrate into the sir, the CBD, sir. Or complete
CBD. Okay.
Yes, sir.
So how do you think it will infiltrate the CBD? How does it happen?
Sir, sir, direct, sir, lateral infiltration or sir.
Or through the duodenum, transcoelomic, or
Yes, sir.
transaerosal?
Yes, sir.
Are you sure?
Sir, transcoelomic, yes, sir. The infiltration, it can occur, sir.
It cannot occur. It cannot occur. So there are some glands in duodenum which prevents the formation of malignancy. So what are the glands in duodenum? So always you see carcinoma stomach, right? So
Yes,
most
sir.
of the time, even if it is a pyloric cancer, it starts at pylorus, but it will never cross to the duodenum. Very rarely it will cross D1 and D2, but it will easily pass proximally. It will involve the body, even it will involve up to the lesser car and go up even up to the OG junction. The reason is because of some glands in duodenum. What is that called?
So there are Brenner's glands are there.
Brenner's glands. Okay. So there is no usually in the obstructive jaundice happening in carcinoma stomach. It is not because of the direct extension of the disease, but it is because of the nodes in the hilum. Which hilum? Liver hilum. Okay.
Okay.
Nodes, external nodes. So one thing is because of the nodes. Next thing is parenchymal liver metastasis. So these are the two reasons why we get an obstructive jaundice in carcinoma stomach. So if there is an obstructive jaundice in carcinoma stomach, it is a good sign or bad sign?
Sir, it is a bad sign, sir.
Bad sign. Okay. Okay. Now we'll go to the next thing. Any difficulty in swallowing? Why do you want to ask this question?
Sir, I wanted to rule out any esophageal cause, sir.
Esophageal cause of what type of esophageal cause you are expecting?
Sir, any sir, ulcer or any sir, erosion, sir, that may be there, sir.
So already sir told Barrett's esophagitis, everything, right? Okay. Now we'll go to shortness of breath and cough.
So I wanted to rule out any stigmata of metastasis that patient may have.
What type of metastasis?
Sir, the pulmonary metastasis, sir.
So which metastasis is common in carcinoma stomach?
Sir, in carcinoma stomach, peritoneal metastasis, sir, is common.
Okay, next one.
Peritoneal, sir, liver, sir, and lung, sir.
Liver, lung. Okay. So in peritoneal metastasis, what will be the presentation of the patient?
Sir, actually, in peritoneal metastasis, sir, it is difficult to sir, diagnose on clinically or on imaging, sir.
Now, what will happen? What will those peritoneal metastasis do? What will it secrete?
Yes, sir. It will secrete, sir, mucus, sir, basically, sir.
Mucus? Sir?
Yes, sir, yes, sir.
No, it won't secrete mucus. It will secrete fluid, ascites. So how will a patient present with ascites? What will be the patient's presentation?
So patient will complain of abdominal distension, sir.
So abdominal distension, have you ever mentioned in the history?
No, sir.
So that's the most important presentation history, whether it is positive or negative in all intra-abdominal malignancies. You should never forget, like a history of loss of weight, loss of appetite, abdominal distension is must, right? Okay. Yes, now going to bony pain. Any bony pain? Why is it?
Sir, just to rule out any, sir, any bony metastasis, sir.
Bony metastasis. Okay. You have to keep your answer short and sweet, Bansal. You should not extend it. You will be losing your own time because we have to go to the examination. No history of headache, blurring of vision. Why is it?
Again, sir, to rule out any metastasis, sir.
Metastasis. So it's very rare to get CNS metastasis. Okay. Now go to the next slide, please. So treatment history, he has taken some treatment, multivitamins and all these things. The treatment history, the first point, again shows it can be even a benign peptic disease also, right? Okay, so patient went to upper GI local hospital, advised upper GI endoscopy. And so upper GI endoscopy has been done. So what are the histories you will ask when they have done an upper GI endoscopy? So the patient is giving you the report of the upper GI endoscopy. So what are the things you will see in that?
Sir, in that, sir, we'll see the reporting, sir. The report will tell us about the findings, sir, in esophagus, the stomach, and the duodenum, sir. It will tell us about the presence of any endophytic swelling or an ulcer that is there, sir. And if there is a lesion, whether the biopsy, any biopsy has been taken or not, sir.
Okay, good. So what is actually an upper GI endoscopy?
Sir, upper GI endoscopy is a visualization of sir, esophagus, stomach, and the duodenum, sir.
Duodenum up to ligament of Treats?
Ligament of Treats, sir.
Okay. So you have seen any upper GI endoscopy ever?
Yes, sir.
Upper GI endoscope, the scope you have seen?
Yes, sir. I have seen.
Okay. How long is the scope normally?
Sir, I don't exactly remember. I think it was 60 centimeters, sir.
Okay. So what is the length of the duodenum?
Duodenum, sir, it is 25 centimeters, sir.
25. Esophagus?
Sir, esophagus is also 25 centimeters, sir.
So esophagus 25, duodenum 25. Stomach, what will be the length?
Stomach, sir, if we go through the, sir, it is again, sir, 15 to 20 centimeters, sir.
50. Then you need a 1 meter scope, which is very difficult to carry. Then it's almost like a sigmoidoscope. So normally in an upper GI endoscope, you cannot reach beyond D2.
Yes, sir.
Maximum you can go is up to D2. Very rarely D3. Okay. So with this dilated stomach and all, it will be very difficult. So you can visualize only up to the D2. So in an upper GI endoscopy or any endoscopy for that, you have to see is whether it's a complete scopy or not.
Okay.
Okay. Sometimes they might have done just like that. Patient would have been not cooperative. So you have to see whether they have done a complete endoscopy. Next thing is what are the areas they have passed. Then we have to see what are the description has been given. And most important thing in carcinoma stomach case, whether they have passed to duodenum or not. What do you think? The patient would have passed the scope. You have seen the report, right? Where did they pass into the duodenum or not?
Yes, sir. They did.
Yes, they have passed. So in that case, they will mention passed with difficulty or could not pass.
Yes, sir.
Okay. So was it with difficulty or it was very easy?
It was, sir, they didn't write about any difficulty in passing.
Okay, that means it is easy. So in that case, the patient will not present with the gastric outlet obstruction usually.
Yes,
If
sir.
you are able to pass, and you know how much the caliber of the scope, endoscope?
So it is sir 5.2 millimeters.
You just say almost bigger than as your pen, or be almost the size of your little finger,
Yes, sir.
right? So there will not be any obstruction usually. So if there is a scope, they will be able to pass. So which part of the stomach is the most difficult area to pass, which is very difficult to visualize, whether it is the cardia, fundus, or lower
So
esophageal
fundus
sphincter?
is difficult to visualize, sir.
Fundus, huh?
Yes, sir.
No, everywhere you can visualize. Usually you can visualize. Okay, fine. So another important thing is whether you have taken a biopsy or not.
Yes, sir.
So whether they have taken a biopsy?
Yes, sir. They did take a biopsy, sir.
Okay. So in this case, you have mentioned about 2 investigations, upper GI endoscopy and CT. Okay.
Yes, sir.
Suppose the patient has not gone to that patient, the previous doctor. He is
Yes, sir.
coming directly with only the symptoms. What will be the first investigation you will be doing? Is it upper GI endoscopy or a CECT?
Sir, I'll do an upper GI endoscopy first, sir.
Why?
Sir, because sir, upper GI endoscopy is the investigation of choice for upper GI bleed, sir.
Oh, okay. Suppose if the patient is having a malarious stare, it's also will present with upper GI bleed only. So will you do an upper GI endoscopy? Or there is a esophageal perforation? How do you know that?
Yes, sir. Cannot rule
So
out, sir.
investigation wise, always it is non-invasive first.
Okay.
So upper GI is non-invasive or invasive?
Invasive, sir.
Invasive. So always non-invasive. Okay. So no history of any chronic illness or past surgeries. Okay, fine. So in past surgery, so if there is already an abdominal surgery done,
Yes, sir.
okay, is it any risk factor? Abdominal surgery, the patient doesn't know. The surgery was done almost some 10, 15 years back for almost a similar problem. Now the patient is having the same problem. What do you think? The patient has lost all the records. What do you think the surgery would have been?
Sir, the patient might have undergone, sir, some sir, gastrojejenostomy that
For what?
Sir, could have been done due to some sir, as a result of this gastric outlet obstruction only, sir.
Yeah, that gastric outlet obstruction might have happened because of what?
Sir, peptic ulcer disease, sir.
Yeah. So what surgery was done previously? Historic surgery. It's a historic surgery. So they do, and because of that, the patients develop CS carcinoma stomach after some time, like 10 to 15 years later. So what is that surgery?
Sir, after Billroth, sir, Billroth 2 surgery, sir.
What is that? Billroth? Billroth is the name of the person. Tell me the surgery.
Yes. Sir, Billroth 2 surgery, in then that, sir, we do a distal gastrectomy with the
Distal gastrectomy?
Yes, sir.
For benign disease?
Sir, in case of sir, if there is gastric outlet obstruction, sir, and
So there is a gastric outlet obstruction happening because of a benign disease. What surgery you do?
Sir, can you do a sir gastrojejenostomy, sir? A loop gastrojejenostomy.
Okay, along with that, what do you do?
With the sir vagotomy, sir. Could be.
Yeah, what is that vagotomy called as?
Could do truncal vagotomy or selective.
Truncal vagotomy. So how many vagus nerves are there? How many vagus nerves?
Sir, there are 2, sir, anterior and posterior.
Anterior. Which is right? Which is left?
Sir, the left is anterior, the right is posterior.
Very good. Very good. So once you do vagotomy, what happens to the acid?
So acid secretion, it completely decreases, sir.
Decreases. Now you got the point. So malignancy will happen when there is hyperchlorhydria or hypochlorhydria?
Hypochlorhydria, sir.
Hypo. So acid prevents or saves us from getting stomach cancer.
Stomach cancer, sir.
Stomach cancer. So what will happen if these people are continuously putting PPIs, no?
Right, sir.
So they are putting pantacids and all this antacids, pantacids. What will happen? You will get lot of CS stomach in future.
Yes, sir.
So try to do lot of gastrectomies. So you'll have a lot of patients. Okay. So achlorhydria. And another reason for development is what? What will happen when you do a gastrojejenostomy? What enters into the stomach newly?
Sir,
what is there in the jejunum which enters into the stomach, which should not enter?
So bile, sir, there is
bile. So bile is what pH it is?
Bile is alkaline, sir.
Alkaline. Alkaline means how much the pH will be? Can you tell me?
Sir, it is approximately 8 to 9, sir.
Yeah, 8 to 9. So which is more dangerous, acid or alkaline?
So alkali is more dangerous.
Alkaline is always dangerous. So when this biliary gastritis happens, it may produce malignancy. Okay. Can you go to the next slide? Yeah. Family history. So do you think this carcinoma stomach can run in families?
Yes, sir. There are certain familial, sir.
Yes. So carcinoma stomach is one of the cause for familial malignancies. So 6 siblings all in good health. Okay. Non-vegetarian by diet, not a smoker or alcoholic. So anything contributory here?
Sir, the patient consumes a non-vegetarian diet, sir. But
No, I'm just asking anything is contributory.
no, sir.
Nothing. Okay. You can go. Next slide. So summary, as sir told, most important, the positive things has to be mentioned. Okay. Right. We'll go. I think there is lack of time. We'll go to the examination. Anything else, sir, in the history?
I just wanted to ask him, do you know of a famous family where carcinoma stomach was running? It was Napoleon, right? Napoleon.
You know who is Napoleon?
Family.
Yes, sir. It was,
who is it?
Napoleon was a Roman emperor, sir.
Roman emperor.
Oh,
okay. Rome will come and kill you.
Rome was long dead before.
Not at all. Not Rome.
He
was a French emperor.
France. Okay. He's from French. Okay.
Okay.
Napoleon Bonaparte. Okay. You should know everything, man. Okay.
Yes, sir.
Okay. Go to the clinical examination. Yeah.
Yes, sir. On clinical examination, the patient was conscious, oriented to time, place, and person, and examined lying comfortably on a bed. The vitals were stable, sir. The pulse was 84 per minute in right radial artery, good volume. The blood pressure was 96 by 68 millimeters of mercury, measured in right arm in sitting position. Respiratory rate was 18 per minute. Temperature was 98 degree Fahrenheit, and the BMI was 21.9, and Karnofsky performance status was 80%. On general physical examination, there was pallor evident on lower palpebral conjunctiva. There was no evidence of icterus, clubbing, or cyanosis. There was no evidence of any significant lymphadenopathy, including left supraclavicular lymph nodes. There was evidence of bilateral pedal edema present. The patient had a good whole hygiene. On systemic examination of abdomen, the patient was examined in the Willet room in supine position with the.
Shall we finish the general alone first?
Yes.
Yeah. Can you go to the general first slide? Yeah. So patient conscious, it's okay. I think we need not mention too much here, I guess. Next slide. So pallor, why the pallor is there?
So due to ongoing loss as the tumor is bleeding.
Okay, what is the difference between pallor and anemia? Why you have not mentioned it is anemic?
So pallor is a sign, sir.
Okay, what is anemia then?
Anemia is a decrease in level of hemoglobin, sir.
Yeah, so anemia is a biochemical diagnosis. Very good, very good, super. And icterus, clubbing, cyanosis. Why do you expect this to happen? What is this icterus means?
Icterus means sir, yellowish discoloration of sclera, sir.
Which sclera?
The sclera, sir, the sclera above the conjunctiva, sir.
Why is it happening? Why that yellowish discoloration is happening?
Sir, the sclera is sir, rich in elastin, sir. Protein has high affinity for bilirubin, sir.
But bilirubin is there always, no, in our body?
Yes, sir.
Then why it is not happening in normal? Do you have bilirubin in your body now?
Yes, sir.
So then why it is not having affinity now?
Yes, sir. I don't know, sir.
Okay, fine. And it is nothing but when the level increases, only the affinity raises.
Okay, sir.
Okay, so hyperbilirubinemia will cause this icterus. As you told, it has higher affinity. Okay, and why do you see in sclera? What is the advantage? Are you seeing the sclera or something else?
Yes, seeing in sclera, sir.
No, actually, you are not seeing the sclera. You are actually seeing the sclera through the bulbar conjunctiva.
Yes,
there is a conjunctiva covering the sclera, right?
Right, sir.
So where do you see the icterus in the eyes at the time where the patient should be? You use how do you use? You use a torch to see? How do you see?
No, sir, in a natural light, sir.
Natural daylight. Okay.
Really.
So natural daylight, that is very important. And you mentioned about significant lymphadenopathy.
Yes, sir.
So what are the areas you saw? What are the areas you examined to know about the significant lymphadenopathy?
Sir, the cervical group of lymph nodes, the supraclavicular group, sir. And axillary lymph nodes and inguinal lymph nodes, sir.
Axillary and inguinal. So suppose if the same patient is having a left axillary lymph node, what does that mean?
Sir, one group of lymph node or one lymph node palpable is not significant, sir.
No. I'm asking, there's a special condition. What do you mention the left? Why do you want to mention the left? Why not right?
Because sir, drainage of the GI tract is towards the right side, sir. Left supraclavicular lymph
Left
node,
side. So what is that sign called, or what is the name of the node in that case?
Sir, Virchow's node, sir.
Virchow's node. Okay. So what is that sign called then?
Sign is called, sir, Trozius sign, sir.
Trozius sign. What is something called Trozios sign? Have you heard of that? This is Troziers sign, right?
Yes, sir. Yes,
Something
sir.
called Trozios sign. He is a French surgeon. Trozios sign.
Trozius sign, I think, sir, it has something to do with the migratory thrombophlebitis, sir.
Very good. So migratory thrombophlebitis can happen. So you have not mentioned about migratory thrombophlebitis. So
Yes,
that can happen in any visceral malignancy, even malignancy of the bronchus also it can happen. Pancreatic malignancy can happen. Okay. And what is the name? Is there any name of special nodes in the left axilla? Yes, no. You can just go ahead.
I said I do not know, sir.
Yeah. So it is called Irish node.
Please name.
Sorry, sir. Yes, Irish node.
Irish nodes. The purpose of this PG clinics is not to rag you, to learn new things only.
Yes, sir. Yes, sir.
Got it? So if you don't know, tell, we'll tell.
Okay, sir.
You teach us what we don't know. That's all. Just sharing of knowledge. Okay. So
Yes,
this is Irish nodes. Got it? So
Right.
suppose if the same patient is having inguinal nodes, enlargement of tonsil, same symptoms, what is your diagnosis?
Sir, it could be sorry, sir. It could be a lymphoma, sir.
Lymphoma. Excellent. So it can be lymphoma. So why do you think there is pedal edema? You have mentioned as evidence of bilateral pedal edema. What do you think the reason is?
The result of protein allergy malnutrition that has occurred, sir. There could be edema, sir.
So usually anemia will be associated with pedal
Yes, sir.
edema. Anemia will be associated with cardiac failure. Anemia will be associated with congestion, and also hypoproteinemia. All this can produce this pedal edema. So, and good oral hygiene. You need any? Why you want to mention about good oral hygiene?
Sir, just to see, so complete the general physical examination, and there is no staining, nicotine staining or tobacco chewing staining, sir.
Okay, got it. You have mentioned it as for a completion sake. But good oral hygiene is very important in case of total gastrectomy. So when you do a total gastrectomy, if the patient is having caries tooth and poor oral hygiene, there is a very high chance of anastomotic dehiscence. We will be doing an esophagogynostomy. The anastomos may go for a dehiscence. So good oral hygiene is must. Now you can go to the systemic examination, please.
Yes, sir. On systemic examination of abdomen, the abdomen.
Sir, if you want to ask add any points, sir, please, sir.
No, that's fine.
Okay.
Yes, sir. On inspection, sir, the abdomen is scaphoid in shape with normally inverted umbilicus. There is evidence of epigastric fullness. There is no evidence of any scar mark or dilated veins or any periumbilical nodule visible. All quadrants, they move equally with respiration. The hernial sites, they are free with no renal angle tenderness is there. External genitalia, they appear normal on inspection, sir. On palpation, there is
no. I'll stop you here. Okay. So the most important thing in inspection is I have even mentioned in history, which you missed in history. What is that? VGP. What is that?
Visible gastric peristalsis. Yes,
so
sir.
that has to be mentioned. Okay. So what is that? How it will be visible gastric peristalsis? From where to where it will be?
Sir, it will be seen in left to right, sir.
Left to right. So why does it happen?
As as the stomach is distended, sir, and as the peristaltic waves they start from the GE junction, they go towards the pylorus, sir. So that visible the peristalsis that would be visible, sir.
Okay, so just a small one question only. So if you see a gastric carcinoma proven with
Yes, sir.
mass and another patient, same symptoms, same history, same diagnosis, without mass, which you would like to operate?
Sir, same history and okay.
Same, everything is same. Patient A with mass, patient B without mass, which you would like to operate?
Sir, without mass, sir, as the tumor size would be smallest in that
Yeah,
case.
most of the time, if the tumor is palpable in carcinoma stomach, if the tumor is palpable, it will be already inoperable. So that's
Yes, sir.
how. And another thing is, you mentioned about this thing moves with respiration, all quadrants. What about the tumor, or what about the epigastric fullness, whether it is moving with respiration or not?
Yes, sir. That too is moving with respiration, sir.
So that has to be mentioned. That is missed here. And also, you have not mentioned about the pulsation. Pulsations,
yes, sir.
pulsations. So what pulsations you will see? If there is an epigastric mass, what pulsation you will see?
Sir, in an epigastric mass, we would see, sir, transmitted pulsation, sir.
Yeah, transmitted aortic pulsation. Okay,
Aortic
because
pulsation.
already the patient is asthenic, ill-built, ill-nourished, so there will be some transmitted pulsation that will be usually seen. Okay, yeah, you can go to the next slide. Yeah.
So on palpation, so there is a single non-tender intra-abdominal lump palpable in the epigastric region. It measures 8 centimeter in length in midline and 12 centimeters across. It's firm in consistency with well-defined low margins, with the upper limit obscured by costal margin, smooth surface, unable to insinuate fingers between the swelling and the costal margins. It is moving with respiration. There's no evidence of visible peristalsis. Rest of the abdomen, it is unremarkable on palpation. The liver edge, it is palpable 1 centimeter below the costal margin in mid-clavicular line. There's no evidence of splenomegaly. The bilateral testes, they are palpable normally. On percussion, the dull note is heard over the swelling. There is no evidence of free fluid in abdominal cavity on percussion. The liver span, it measures 13 centimeters craniocaudally in a right mid-clavicular line. On auscultation, normal bowel sounds are heard. There is no evidence of any bruit over lump. There is no evidence of any succussion splash. On rectal examination, it was unremarkable. There is
Can you go to the back, please? Yeah. So anything different in palpation in carcinoma stomach? Any different extra palpation or auscultation or percussion? You call it as? Have you heard of ausculto percussion?
Yes, sir. On ausculto percussion, sir.
So that has to be mentioned. Yeah.
Right.
So how do you do an ausculto percussion?
Sir, I've heard of.
No, have you ever done it, or have you ever seen somebody doing it?
No, sir.
So you keep the bell of the stethoscope
Yes,
over
sir.
the lump, or just close, just not over the exactly over the lump, but it should be left side where the stomach is dilated. From there you draw with a pencil, draw radial lines, okay, all around like a sun rays, okay. So at some point of the time you will see a change in note.
Okay.
You will hear a change in note. So you mark that point. So if you make multiple lines, you will have a multiple points. If you draw those multiple points, it will be a curve. So that curve is nothing but the enlarged greater curve of the stomach. So it is called ausculto percussion. Okay.
Right.
So palpable, you have mentioned a single non-tender intra-abdominal, and the most important thing most of the people miss is the plane of the swelling. Plane. So where do you think the plane is? You have not mentioned about that.
Sir, it is intra-abdominal, sir.
So how did you make it as intra-abdominal?
Intra-abdominal, sir. After sir, I performed a leg raising test, sir. Where there was epigastric fullness, it disappeared, sir.
Okay, fine. And rest of the abdomen is unremarkable. So in the previous thing you mentioned about the umbilicus is inverted. Suppose
Yes,
the
sir.
umbilicus is inverted or there is a nodule or ulcer in the umbilicus. What does that mean?
Sir, a nodule or an ulcer, it is indicative of sir, metastasis, sir.
So what is that nodule called as?
Sister Mary Joseph nodule, sir.
So what is the stage then?
Sir, that is sir, M1, sir.
M1, okay. And liver edge is palpable, okay. No evidence of splenomegaly. Bilateral test is palpable and normal, okay. Go to the next slide. So percussion dull, evidence of no evidence of liver span, okay. So here you have to mention about ausculto percussion, okay. Normal bowel sound, succussion splash. What is that succussion splash means?
Sir, in succussion splash, the stomach, sir, it contains the sir, the food contents as well as the air, sir. So on sir, when we vigorously shake the patient and we auscultate, sir, a splashing sound may be heard, sir. That is the
So
succussion
here
splash.
you have mentioned it is not heard. Why it is not heard?
Because sir, there is not a complete gastric outlet obstruction, sir. So
No,
patient,
it's not like that.
yes, sir.
It's not like that. If there is the stomach is completely filled, it will
Yes,
not have a succussion splash. It should have some air. Then only you'll be able to hear the succussion splash. Yeah. You can go to the next slide. Yeah. So perrectal examination. So what do you expect in perrectal examination?
I'm sorry, sir. Sir, in perrectal examination, there could be sir, stigmata of metastasis, sir. That is
What you will see?
in blemishes. There is be sir hardness of the anterior sir, rectal wall, sir.
Why does it happen? How does it metastasis there?
Sir, it is a transperitoneal spread, sir.
So it is actually peritoneal metastasis. Okay, it's a drop metastasis to the rectal mucosa or the serosa actually. Okay, peritoneum or the rectum. Next slide.
Rest
Yeah,
of
you
the
can present.
examination was normal, sir. Sir, to summarize, the patient was a 52-year-old male without any comorbidities, with loss of appetite, gradually progressed to vomiting, passage of black stools for 3 months, without any history of abdominal pain, and with presence of paler and pedal edema examination and a single non-tender intra-abdominal lump in epigastric region, sir. So, sir, my provisional diagnosis is a gastric malignancy, sir.
So gastric malignancy, you have to quantify further. So whether it is proximal, distal.
Yes, sir. It appears to be a distal gastric malignancy, sir.
Distal gastric malignancy. So with the gastric outlet obstruction. So
Yes,
for carcinoma, if you mention the diagnosis like this, so you can mention it as a differential diagnosis. So if you are committing the diagnosis in a clinical examination to mention, it is a probably carcinoma stomach or a distal cancer, distal gastric growth, okay, with
yes,
the gastric outlet obstruction and without evidence of any metastasis.
Right, sir.
So you have mentioned so many negative points, so that also has to be included. So, sir, any questions in examination, sir?
We are fine, sir. Thank you, sir. Please, sir, continue.
Yeah. So next, what is your next step?
Sir, we'd like to sir, investigate this patient further, sir. So in gastric outlet obstruction, sir, we'll go in for sir, CCT abdomen, sir. Then we'll.
Do you like to do a CECT abdomen directly or anything else you want to do?
Sir, if we are suspecting malignancy, so then even for staging purposes, sir, we'll go for a CT abdomen and upper GI endoscopy because of upper GI bleed, sir. So upper GI endoscopy will also has to be done, and that will help us in getting tissue diagnosis as well, sir.
So usually the diagnosis can be made with just an ultrasound first. So ultrasound abdomen. So if the ultrasound abdomen shows a liver metastasis or a free fluid, automatically it upstages the disease. It will give you an idea. So no need to go directly into high-fi diagnosis, high-fi investigations. So ultrasound will be available everywhere. So ultrasound abdomen. So what are the things you are going to see? Ultrasound abdomen will show a growth in the stomach, will show the nodal status, and also will show you the whether there is any liver metastasis or not. Okay. Next thing, you can take a CT. So
Right.
CT, for taking CT, what is more important here? Whether you want to do with contrast, without contrast, where you will give the contrast.
Sir, we'll get a contrast CT, sir. Basically, sir, CT is done to characterize the lesion and
Contrast, how you will give the contrast? Oral, IV, intra-arterial, intravenous, intrathecal?
Sir, both, sir, IV and oral contrast will give, sir.
So what do you expect in this patient? Where will be the contrast orally? If you give the oral contrast, what will happen to the contrast?
Sir, oral contrast, sir, sir, it will, go in the stomach and it will be collected there, sir.
It will be collected there because if it is a complete obstruction.
Complete obstruction,
But you
sir.
already told the endoscope has
Again,
been
yes,
passed
sir.
beyond the
Yes, so
codon.
that will pass.
So
through, sir.
it will pass definitely. And next thing is IV contrast. Why do you need an IV contrast?
Sir, IV contrast is to characterize the vascularity of the tumor itself and to see for the metastasis, sir.
Yeah, there will be any enhancement will be there because of hypervascularity, whether it is a primary or the metastasis or the nodes. So all these things you will see. So what are the things you will see in CT scan of the stomach in a stomach cancer patient? So what are the things you want to see? Just enumerate.
Yes, sir. Sir, first we'll see the tumor itself, sir. The location of the tumor and the characteristic of the tumor. Is it proliferative, ulcerative, or infiltrating, sir? And then, sir, we'd like to see the spread, sir. The metastasis to either, sir, there could be an peritoneal metastasis or liver metastasis. Presence of ascites, if it is there or not, sir.
So basically, you want to assess the metastasis as well as the local extent of the disease. So what is the most commonest organ to get involved in carcinoma stomach? I'm not asking about the metastasis, the commonest organ involved in a locally advanced carcinoma stomach. Mostly. And what is the reason for, because of that reason, that stomach cancer may become inoperable? So what is so close, the organ very close to the stomach?
Peritoneum, sir, the visceral peritoneum.
No, peritoneum will be there with all.
Yes,
so, and peritoneal, the visceral peritoneum will be infiltrated by the tumor. So what is the organ just behind the stomach?
Sir, the pancreas, sir.
Pancreas. So pancreatic infiltration may make it is inoperable. So pancreas is posterior. So how do you want to take a CT? The CT is going to be taken. You are sending the CT. So you want to give any special instruction to the CT technician how it has to be taken? Okay, so in other words, you wanted to take the CT to know the plane between the pancreas and the stomach. Right, stomach growth. Okay. So how will you assess that? What will be the position of the patient?
Okay, the patient has to be in a prone position.
What is this? What is this called? This knee elbow position test, which we don't do because it is painful. In knee elbow position, what happens? Why do you want to do a knee elbow position test?
Sir, in knee elbow position, any intraperitoneal swellings, they will fall, sir, downwards basically.
It's basically falling forward of an intra-abdominal tumor to differentiate it from a retroperitoneal tumor.
Retroperitoneal tumor. Yes,
so, in this case, how do you want to take the CT now? Tell me.
Yes, sir. It will be done in a knee elbow position, sir.
No. You cannot put a patient in knee elbow position in the CT scan. It will get stuck. So you have to make in prone position.
Yes, sir.
Or lateral position. So that will help us to know the plane between the pancreas and the stomach growth, gastric growth, right? Okay. So these are the things you want to see in the thing. So next, what do you want to do?
Sir, after that, sir, we can go for a tissue diagnosis, sir.
Yeah, endoscopy has been done. Tissue has been taken. So
yes,
what do you expect in the diagnosis?
Sir, adenocarcinoma, sir.
Adenocarcinoma. It is coming as poorly differentiated adenocarcinoma. So what do you want to do?
No, sir, poorly differentiated, sir. We'd like to go for neoadjuvant chemotherapy, sir.
Why neoadjuvant chemotherapy? So patient is already having vomiting.
Yes, sir.
Okay, so chemotherapy commonest side effect is vomiting only. So again you are increasing vomiting. Patient is having black tarry stools. There is loss of blood. You want to correct the anemia? You want to see how much the hemoglobin is?
Yes, sir. Yes,
So
sir.
how do you know? How do you know the hemoglobin status?
Sir, we'll get to the baseline investigation, sir.
So what are the baseline investigations you would like to do? Biochemical investigations.
Sir, CBC, sir, SCRFTs, LFTs, sir.
What is it? Yes, RFT.
Serum electrolytes, sir, and renal function test, sir.
Okay, and in all examination, whether it is university, local examination, or online Zoom examination, always avoid abbreviations.
Right, sir.
Because examiners doesn't like abbreviations. So CBC. Okay, CBC means what? I don't know what is CBC.
Yes, sir.
So complete blood count. Okay, so in complete blood count, what do you expect in this patient?
Sir, it could be
Hemoglobin, how it will be?
sir, it will be low, sir. It will be the hemoglobin would be low, sir, and
No, that the patient himself will know it is low. What
yes, sir.
do you expect? Patient is having pedal edema, pallor is there.
Yes, sir. There would be severe anemia, sir.
Yeah, severe, at least 6 to 8.
Yes, sir.
Even less than that. Okay. And what about the WBC? I am telling the WBC is 1 lakh. What do you think?
Sir,
is it normal?
No, sir.
So what do you think? Can you clinch the diagnosis? 1 lakh WBC gastric growth. What is that?
Sir, it could be, sir, lymphoma, sir.
Lymphoma. Okay. So do you want to take the liver function test?
Yes, sir.
Why?
Liver function test, again, sir, to rule out, sir, metastatic, sir. Metastatic.
Okay. You told something called SR. What is that? Serum electrolytes.
Serum electrolytes, sir.
So what are the electrolytes you want to check?
Sodium and potassium, sir. Sodium, potassium, and chloride, sir.
Chloride. So what will be the status in this case, in this patient?
Sir, the patient will be having a hypokalemic metabolic alkalosis, sir.
Metabolic alkalosis. So how the pH will be?
So pH will be some more than 7.4, sir.
Okay. So you need to do so many things. Correcting his metabolic alkalosis, correcting anemia. Okay, he is already hypoproteinemia. You told no because of these things. So these things has to be corrected before initiation of our treatment, whether it is chemotherapy or surgery. So I asked the tissue diagnosis as poorly differentiated. So poorly differentiated means it can be even a lymphoma. Okay, so how will you differentiate a adenocarcinoma from a lymphoma? What additional test you will do?
Yeah.
What can you get a histopathology, slides, blocks?
Yes,
you can do some other extra investigation. What is it called as?
Sir, immunohistochemistry, sir.
Immunohistochemistry. So what immunohistochemistries you routinely do in gastric growths?
Sir, for CD117, sir.
CD117 is for GIST, not for lymphoma.
Yes, sir.
CD15, CD30, and CK5 and 7. Okay. So if it is 5-7, it is adenocarcinoma. CD15, 30 means lymphoma. Okay. And do you know anything called Hernia?
Yes, sir.
What is it, Hernia?
Sir, Hernia is also the tumor marker, sir. That is
tumor marker.
What is there? Sir, that is sir, it is also immunohistochemistry is done for that also.
Yeah, what is that actually, Hernia? Where in which malignancies you routinely do Hernia?
Sir, in breast malignancies, sir.
Breast malignancies. But now, even for gastric malignancies, you have to do. If it is positive, we can include trastuzumab, that is, which is an anti-Hernia immunotherapy along with the chemotherapy, right? So you get the diagnosis as moderately differentiated adenocarcinoma. And CT scan shows it's a localized disease. Okay, no ascites, no liver metastasis, pancreas free. What do you want to do now?
Yes, sir. After correction of the metabolic abnormalities, and building up.
How will you correct the metabolic? How will you correct the metabolic abnormalities?
Sir, will give normal salines with the potassium replacement, and additionally for a severe anemia will build up, will transfuse blood. Sir.
So and, what type of metabolic alkalosis you told something? No, what is it? Hypo something.
Hypokalemic, sir.
Okay, what does this normal saline contain?
Normal saline contains, sir, sodium and chloride, sir.
So what about hypokalemia? How will you correct the hypokalemia?
Sir, sir, supplement potassium, sir.
Yeah, potassium has to be supplemented. So it is, you have to give sodium, chloride as well as potassium. So what IV fluid is contraindicated in such cases in GOO, that is gastric outlet obstruction?
Sir, ringer lactate, sir.
Ringer lactate. Why?
Because alkalosis, sir. The lactate will produce bicarbonate, sir.
Lactate is what? Lactic acid only, no? It is acid, right? How does it become alkalosis then?
Sir, it is broken down, sir. Lactate is broken down in
बहुत सुंदर है.
Yeah, right. So RL, that is ringer lactate, is contraindicated in GO. Okay. So you have corrected anemia, you have corrected proteins, and you have corrected IV fluids with the serum electrolytes, everything. So what is your next step?
After, sir, sir, we plan the patient for a diagnostic laparoscopy, sir.
Okay.
Then
What do you want to diagnose extra?
Sir, the peritoneal metastasis, it might be missed in imaging, sir. So,
okay.
And then if there is no evidence of peritoneal metastasis, we can proceed with resection of the tumor.
So what is the surgery you are going to proceed with?
So depending on the location, distal, sir, we can go in for.
So the location is already given. It is distal growth. It is not involving any other organ. Duodenum free, pancreas free, minimally enlarged nodes, perigastric nodes. So what is the surgery now you are going to do?
So we'll go in for subtotal gastrectomy with the Roux-en-Y gastrojejunectomy, sir.
Very good. You want to do anything for the nodes?
Sir, one more thing. Sir, one more thing. See, Ishan, before going in for a definitive surgery, any other particular thing you want to check or you want to do apart from a CT? You have done a CT before now doing especially for a distal stomach malignancy. Anything, any other thing you want to do? Just before surgery, definitive surgery.
Sir, first, we'd like to rule out any evidence of metastasis, sir, basically. So, CT, chest and abdomen has to be done, or a PET CT could be done, sir.
No. There is no role for PET CT in case of a carcinoma.
PET CT need not be done. PET CT need not be done. PET CT is not a diagnostic.
Yeah. What is the importance of diagnostic laparoscopy?
Sir, diagnostic laparoscopy will help us in determining whether the growth is resectable or not.
No. See, for all carcinoma stomach, most commonly proximal stomach lesions that we usually favor. Definitely, before going for it can be an open or a laparoscopic surgery, the definitive surgery itself. We always do a laparoscopic view because what is the incidence of occult peritoneal metastasis in carcinoma stomach?
I'm sorry, sir, I don't know the exact figure.
Yeah, it comes around. Yes.
Yes, sir.
Yeah, Bansal, go ahead.
Yes, sir. The imaging, it is unable to pick up, sir. Up to 60% of the cases, it may be missed in imaging, sir.
Yes. See, usually what is given as standard is a 30 to 40%. 30 to 40% of peritoneal metastasis can be missed. Okay, so that is very important because that whole situation itself changes, or the scenario itself changes when you go for a definitive plan procedure rather than we going for any other new adjuvant chemo or chemotherapy. Okay. So one more question. See, if it is an inoperable case, or if it is it's not a inoperable or locally advanced lesion, what is the commonest regimen now that is used for stomach?
Sir, there are various regimens that are available. Folfox is there, sir, and Capox regimen is also there, sir, perioperatively, that is given for 3 weeks before the surgery, then post surgery, using oxaliplatin and capecitabine.
Yeah, platinum based. It is the platinum based. Cisplatin based ones that are more preferred. One more thing. See, if you are going for a plan, a new adjuvant chemo, and then you are going for a definitive surgery or something like that. Any other palliative procedure in between you like to do, especially for a distal stomach lesion?
Yes, sir. Sir, gastrojejunostomy can be done, sir. bypass-
This is an era of minimally invasive things. Would you go for a gastrojejunostomy or something else?
Or a feeding jejunostomy, sir. Yes, sir. Feeding
No.
jejunostomy.
No. What is SEMS? SEMS. What is SEMS?
What is that stent called? What is SEMS stent?
Self-expanding, yes, sir. Metallic stent, yes, sir.
Metallic stent.
And endoscopic stenting, sir. Yes, sir.
So what is
Yes.
the problem for the patient? It's a gastric outlet obstruction, right?
Yes, sir. Yes, sir. Right, sir.
So first of all, you address the symptom.
Right,
So
sir.
you
Right.
put a SEMS. So gastric outlet obstruction disappears, and then you can start the neoadjuvant chemotherapy.
Right.
So the
And
standard
one more-
neoadjuvant chemotherapy is ECF regimen perioperatively, but now it is getting outdated. We use oxaliplatin, EOX. Now even that is also changed. FLOT regimen, FLOT, FLOT.
Yes, sir. Okay.
So you add Taxols also.
Taxanes also is added now.
Yeah.
And see, one more thing, in biopsy, you have taken a biopsy from the malignant lesion. Okay,
Yes.
in the stomach by endoscope, you have taken a biopsy.
Yes,
Now,
sir.
what is the any critical marker now you look for? Like similar to breast malignancy and all, we look for some IHC markers. In stomach now, any markers? Now, it is because that has come out as a recent guidelines, especially in NCCN also it is given that is
Sir, Hernia, sir.
Hernia. What is the importance?
Sir, in Hernia, if there is the immunohistochemistry is positive, sir, we can add trastuzumab as a targeted therapy, sir, for that patient.
Not only adding trastuzumab, see that indicates it is going to be a very grave prognosis.
Yes, sir.
The grade and whole thing will change.
Right,
Okay,
sir.
the whole thing will change, and it is going to be of very poor prognosis.
Right,
Okay, sir.
Yeah. So what type of surgery you are now planning to do? So you
Yes,
mentioned
sir.
about the resection.
Yes, sir.
What about the
With
node?
D2 lymph node dissection, sir.
So what are the nodes you will be removing in a distal growth?
Sir, in a distal growth, sir, will be removing, sir, the D1 nodes that are stations 1 to 7 that are present in the perigastric area, and
1 to 7.
1 to 7 lymph node stations, and
So
then
I'm just asking you. So what is station 1?
sir, station 1 is right cardia, sir.
So for a distal growth, you would like to remove that perigastric node in the station 1 and 2 also?
Sir, yes, sir.
Have you seen a gastrectomy surgery?
Yes, sir.
Okay. So what type? Proximal or distal?
So total gastrectomy, sir.
Total gastrectomy. Very safely you are playing. Okay. So actually these perigastric nodes, lymph nodes will be very close to the vessels supplying the stomach. Okay. So
Right.
you will not be able to do a removal of the nodes without compromising the vessels.
Okay.
So you will be devascularizing it. Okay. So it is usually the perigastric nodes which is close to the tumor. So what is stage for station 5 and station 6? What is that?
5 and 6 is, sir, the suprapyloric and intrapyloric, sir.
So usually for a distal growth, it is 2, 3, 4, and 5.
Okay.
Not 2, 3, 4, 5, and 6. Okay. So what is the difference between D1 and D2 dissection?
Sir, in D1 dissection, we are dissecting the nodes that are basically perigastric, that are located.
Yeah,
close
1 to 6. And what about D2?
And in D2, sir, the major arteries that are there, the splenic artery, the hepatic artery, the celiac artery.
So
Sir,
nodes along the named vessels.
Named vessels.
So the
Yes, sir.
gold standard is D2. Okay? So it is D2 subtotal or distal radical gastrectomy with Roux-en-Y anastomosis, you told. So what is that Roux-en-Y? Can you just elaborate?
Yes, sir. Roux-en-Y, sir, gastrojejunostomy, sir, in which we resect the segment of jejunum, sir, 30 centimeters from the ligament of Treats. We bring it up through the retrocolic tunnel, and we anastomose it. Could be a hand-sewn or a stapled anastomosis, sir. And then, sir, the distal limb is again it is anastomosed with the in continuity with the
So
rest of
usually usually how many anastomosis will be there in a Roux-en-Y anastomosis?
Sir, in Roux-en-Y anastomosis, there could be 1, 2, and 3, sir.
So what are the three? Can you tell me?
Sir, there is first is the sir, the gastrojejenostomy itself,
Okay.
and then the jejenostomy,
Okay.
and jejenostomy is there, sir. And there is
No.
basically, sir, yes, sir.
No. Second is the jejenostomy. What is the third anastomosis? You mentioned about three anastomosis, no? One gastrojejenostomy.
Yes, sir. Yes, sir. So one is gastrojejenostomy, then jejenostomy, and yes, sir. Sir, there are only two, sir.
Only two. It's only two. Only the
Yes, sir.
difference is the
Yes,
way
sir.
you do it.
Okay, yes, sir.
Okay. So,
Right.
so you what is the next step you do? You have done the surgery. Well, okay. What is the next step you do after a cancer surgery? What is the next important thing you do?
Sir, then is the sir post-operative management and the histopathology basically reporting, sir.
So histopathological examination. So main thing is you have to send the nodes separately.
Yes,
So
sir.
from which part you have taken, whether it is a station 4 node or station 5 node
Right,
or a station 7 node, it has to be sent separately because that will change the diagnosis, the
Right.
stage. Okay. So, and also what are the things you see is the stage, how much it has spread. You know about staging. We are not going to discuss that. And if the stage is stage 2, pathological staging is T2 and N1, M0. So what will be the next step?
Sir, actually, we can go for adjuvant chemotherapy.
So most of the answers you are answering is we can, we may.
Yes, sir.
That is not at all right. We have to.
We have to, sir. Okay.
So if you tell the
We're going
patient that
for-
he can do, then he will never do.
Okay, sir.
So guidelines means it has to be, it's plus or it is not like plus or minus. It has to be done.
Right.
So adjuvant chemotherapy has to be given. Okay. And most important thing in gastric cancer is you have to look for the margin status. So
Right.
all these hollow viscous organs, you will have 3 margins. Can you tell me the 3 margins?
Sir, the proximal and the distal margin is there, sir.
And any other margin you know? It's called the circumferential margin.
Yeah, okay, sir. Right.
Circumferential margin. It's there for all viscous structures. Suppose we are mentioning about this D2 gastrectomy, no?
Yes, sir.
D2 gastrectomy. The most important thing is you have to remove the something posterior. What is that called? Posterior to the stomach. What is it called as? What is the structure immediately to the posterior to the stomach?
Sir, that is immediately posterior, sir. That is pancreas is there, sir.
Pancreas. What is the structure between pancreas and stomach?
Sir,
The potential space.
yes, sir. The lesser
Lesser sac. So it is nothing but the omental bursa. So you have
Yes,
to
sir.
remove the omental bursa also. The wall of the omental bursa, anterior wall is formed by the visceral peritoneum of the stomach, the posterior wall,
Yes,
and
sir.
posterior wall of the omental bursa is formed by the pancreatic fascia.
Okay, sir.
So in a radical gastrectomy, you have to remove the pancreatic fascia also. So that is called as bursectomy. So that only will give a negative circumferential margin, right?
Okay.
So I don't know whether Kanagavel sir will allow us to go ahead or we need to stop. Sir, please, sir.
Sir, we are already a little on the beyond time.
Okay, sir.
I would request you to give the closing comments, sir. I think the candidate was taken through the entire clinical part, the management part in a very logical fashion. Maybe we have to now give the candidate a chance to ask his doubts, if any, or take clarification from the faculty here. Okay,
Yes,
do you have any doubts here?
Yes, sir. Sir, regarding the adjuvant and neoadjuvant therapy, sir, there are no clear consensus on that. You can clarify.
Okay, you just want to know whether we'll be giving a neoadjuvant or we are going to take a primary surgery, right?
Yes, sir. Yes, sir.
So you do a CT scan, all investigations, everything, diagnosis there, metastatic workup is done, it is non-metastatic disease. Suppose if the disease is bulky, if it is a locally advanced disease, so definitely the ideal thing, gold standard now is you have to go with the neoadjuvant chemotherapy. The only hindrance in starting neoadjuvant chemotherapy is if the patient is having a gastric outlet obstruction.
Okay.
So we need to address gastric aortic obstruction before sending for the neoadjuvant chemotherapy. So the option is, one thing is to do a gastric do a pyloric dilatation. If the patient is endoscopy is being passed, it will definitely dilate it. And the another option is to put a SEMS or a self-expanding metallic stent. There is always a risk of stent occlusion, re-block is there. But once you start the chemotherapy, if it is a responding tumor, automatically it will be maintained. The caliber will be maintained.
Yeah.
Suppose if the SEMS is not working, you are not able to pass the endoscope also, then there is no other option but to do a gastrojejunostomy, either a Roux-en-Y or a regular anterior GJ only, and send the patient for chemotherapy. So if the tumor is very much bulky and multiple perigastric nodes are there, the adjacent organ involvement is there. So in that case, even if you give a neoadjuvant chemotherapy, it is not going to respond. So this neoadjuvant chemotherapy is basically, it is like a culture sensitivity. So for in microbiology, you do a culture sensitivity in vivo testing. So similarly, you test the malignant cells in vivo whether it is going to respond or not. So ideally, this neoadjuvant chemotherapy will classify these tumors into responders and non-responders. So non-responders will progress. So they will become more locally advanced and they become a metastatic disease. If they are responders, the stage will be downstaged and the patient will come for surgery. So nowadays with the present regimen, so as I told you, initially we were using a regimen as ECF, that is epirubicin, cisplatin and 5-fluorouracil. It is very difficult because you have to give the 5-fluorouracil as an infusional. Infusion means continuous IV drip, maybe for 4 days, 5 days, and in some centers even 21 days also. So now with they have replaced this cisplatin and 5-fluorouracil with oxaliplatin and oral capecitabine. So oral capecitabine will be given for 14 days and 7 days holiday. So that was very easy. But the only disadvantage, EOX regimen responded mostly to the proximal stomach cancers like cardiac cancer or lower esophageal cancers. They responded very well, but the distal cancer were not responding. So as of now, the new regimen is FLOT regimen. So you add taxols, either a docetaxel or a paclitaxel, so that will respond. So as of now, the guideline for neoadjuvant chemotherapy is, if you see the stomach thing is locally advanced, multiple perigastric nodes are there, suspected involvement of adjacent organs like pancreas or close to the CBD, or there might be a duodenal involvement, you go for a neoadjuvant chemotherapy. The only hindrance is the obstruction. The obstruction is not there, definitely you send for a neoadjuvant chemotherapy and you have definite good results in the surgery, and doing the surgery also will be very easy.
Okay, sir.
Any other clarifications you want?
No, sir.
You did an excellent presentation. You did an excellent presentation, in detailed presentation, and only thing is some of the points you have missed it. So some points, some special points like occipital percussion, the plane of the tumor, visible gastric peristalsis. So some of the things are very much specific to stomach, and all the examiners are very much interested in asking those things. So if you miss those things, that may give a negative point to us. Otherwise, your presentation was excellent, and you continue to present many cases so that you will have a fluency, so that you will not waste time and you will be able to present it friendly. You are in second year or final year?
So finally, sir.
Final year. Best wishes for a wonderful career.
Okay, sir.
Yes,
Sir, thank you, sir. Kanagal, sir, thank you for the opportunity, sir.
Thank you, sir. Thank you very much, sir. Thank you for joining and staying till late night.
Thank you, Kanagal, sir. Yes,
Thank
sir.
you.
Thank you, sir. Thank you for giving this great opportunity.
Dr. Shrikmar sir still logged in, Ambuja Madam, Rajiv Sakai sir, all others. Thank you for joining this Friday. We look forward to have you on board coming Friday. And with the permission of faculty, I wish both the candidates, Dr. Ishan and Rofat, for contributing today's cases. And thank all the faculty for contributing your wisdom. Good night, everyone. With the permission of the faculty, I call this session a close and wish you a good night to all of you.